Sorry for that tease. Swear we'll take a break in a minute. So generation. So we have 5 generations of cephalosporins now. And we used to think that the generations mattered in terms of the risk of cross-reactivity. And it does seem that way. But as you noticed in this previous slide here, only the first and second generation cephalosporins have this side chain issue. And so the reason that the risk is higher amongst the first and second generation is not because of the generation they're in. It's simply because there's those that have the same side chain in those generations. Once you get to the third, fourth, and fifth, so your ceftriaxones, your cefixienes, you're not going to have that same issue. And so the risk for third and beyond is very, very low, if not zero. So this is the way that I kind of approach how I'm going to think about using cephalosporins. So if I want to use a first generation cephalosporin and the allergy to penicillin was anaphylaxis, I have a plus minus there because I know in this room you might be uncomfortable with that. According to all the data, you should be able to use it. But I know you're probably not going to want to do that, and that's fine. So that's why I have the plus minus there, but you're probably okay. If it's a first or second generation cephalosporin that shares the same side chain, you should avoid that because there actually is a true risk of an allergy because you're going to have a similar reaction. If it's not anaphylaxis, so something lesser, and it's a different side chain, then you should be able to use it. Second generation with a different side chain, fine. And then third, fourth, and fifth, we don't have that problem anymore, so you should be okay to do. So when I see a penicillin allergy and I want to give ceftriaxone, I honestly don't really think twice about it. If you want to get more into the weeds, you can email me separately. We actually have a test dose protocol in our ED, so if we really were concerned, we give a patient 10% of the dose, see how they do for half an hour, have the epinephrine and everything available just in case. We haven't had a single reaction doing it that way. And then they get the full dose and then we update their chart to say that they're fine and they can tolerate whatever one we want to use. So going back to our case, we had the resistance to what we initially prescribed. So the question is, what do you want to use here? And this is an outpatient, so you're probably not going to want to use ceftriaxone. Nitrofurantoin may or not be appropriate where you are. So I chose cefixime for this one. I'm not worried about the penicillin allergy, and we can use this without a problem. Okay. Why don't we stop? Why don't you get your food, and then we will continue. I don't want to keep you waiting any longer. Go ahead. We'll take a quick break here. For those online, we're just going to grab some coffee and juice.
It was really difficult as we came in.
Carrying on. Oh, no. But you don't want to be the first where I have to call a lawyer and say, oh, shit, you know, my alert. But that's why, so I'm now saying, your first dose is going to be half an hour. And then we'll say, because you're not looking. Because like you said, the likelihood someone says, I don't remember, or I had it as a kid. Probably the sounds that's the side effect of strep throat, but not why they were told. Really nauseous. Oh God, everyone's nauseous. Yeah.
For those online, just give us about 60 more seconds. All right, let's get back on track. The good news is we're all emergency clinicians, so we know how to deal with change and changes to our routine. The next thing I want to talk about is something that I find is a common practice, and that is that we want to use IV for everything. I don't know if we want to, but it seems that we do. So I want to talk about the difference between IV and oral routes. I think some of us think that in order to justify an admission, we might need to give them IV antibiotics, or maybe it's that they work faster or work better. But it's not actually always the case. I want to harken back to a term that you probably haven't thought about in a while called bioavailability. And all this means is that if you give an IV version of X drug, you assume that 100% of it is going to get absorbed. And bioavailability just means that if you give the same version of that drug orally, what percentage is now going to be absorbed. And if you look at a lot of the antibiotics that we give in the ED space, most of them have pretty high oral absorption. You'll notice that there's a couple of cephalosporins that don't have the best absorption. We'll come back to that a little bit later. But overall, we actually, most of them have pretty good absorption. So we can't really use that as an excuse for justifying why a patient has to get IV therapy. In fact, many of the major guidelines out there today, including community-acquired pneumonia, skin and soft tissue infection, and UTI, all recommend that we give oral antibiotics for a lot of the scenarios that we're going to see. So for mild cases, we should almost always be giving PO. And obviously the mild, moderate, and severe are going to differ depending on the infection. For moderate, even if they're a little bit sicker, most of the time you can get away with oral therapy. And in the severe cases, that's when you start to think about giving IV therapy first. I don't know if you ran into the same problem that we did in America when the pandemic first started, but we had a shortage of toilet paper, among other things. And I bring this up because even giving one dose of an IV antibiotic in the ED, like to get them loaded up before you send the patient home, actually increases their risk of getting C. diff or antibiotic-associated diarrhea within the next couple of weeks after they saw you, which would increase their need for using toilet paper, which is why I brought that up. So my point being is that even a one-time dose of IV antibiotics is not without risk. So just think about that as you're prescribing. And obviously there's some other side effects. These are ones that we don't normally think about all that much, but it's a higher cost. The length of stay might be a little bit longer. There's risk of extravasation, phlebitis. Obviously these are relatively low, but I just wanted to bring them up for completeness sake. Yes?
So you're suggesting that the IV route is a increased risk of C. diff compared to the same antibiotic?
That's correct. Yeah, that's what a couple of ED-based studies have found.
What?
They didn't actually speculate as to the reason. That's a good thought. I don't know. So we're going to now go back to Will's talk from earlier about vancomycin, but I want to tie that into the IV oral stuff that we just talked about kind of as a progression here. So we're going up the scale of Jedi training here, and we're now at the Jedi Knight phase. So I want to make you a master of vancomycin. So we just talked about not giving an IV ×1 dose of most antibiotics. This is especially true for vancomycin. I know it seems like a good idea at the time, like let me load them up with vancomycin and for their skin and soft tissue infection, and then we'll send them home. But that's not a great idea, and I'm going to recommend that you don't do that. Here's one study that I think really drives this point home. There's a group at Christiana Hospital in Delaware that's published a lot of ED-based studies on vancomycin. And one of the ones that they did early on in the mid-2010s was they loaded patients up with either a really high dose of vancomycin, they got 30 mg per kilo, which is a pretty good dose, or the more standard 15 milligrams per kilogram. And what they did is after that one dose, they just measured how many patients were in the therapeutic range after that one dose. And they found that even when you gave patients a whopping 30 mg per kilo dose, only about a third of them got to a therapeutic range. So that one-time dose you're giving really isn't doing a whole lot. It's definitely not in terms of treating the infection that you're trying to get at. But what do we do about patients that are overweight, which we're seeing more and more of in our EDs? And this is just one example of a patient that presented with sepsis who was pretty sick. What's our vanc dose? And as Will mentioned earlier, traditionally or historically, we used to give everyone kind of 1 gram. It was the standard dose. It actually comes in a 1 gram bag. It makes it very easy for everyone involved, including our nurses. But that's actually not what we should be doing. The guidelines recommend that we give a weight-based dose, which is probably what you're seeing now in your electronic medical record. You probably, I imagine, can just pick the weight-based dose. It might even be in some sort of order set. But the dose we use is 15 mg per kilo. And I don't want you to memorize these doses or anything. I'm just kind of pointing out that they're much higher than 1 gram, which is what we used to give. And in the critically ill patients, these guidelines recommend that you stretch that dose to what we saw in that study earlier, up to 30. At my hospital, we tend to cap our doses at 2 grams. If they need more after that, we can kind of figure that supplemental dosing later, but we max at 2 grams, largely because it takes a while for vancomycin to infuse, and you're going to be taking up a line for multiple hours the higher the dose that you give. So we kind of break it up. One of the questions I get asked all the time is, what do I do and how do I change my vancomycin dose if they have kidney dysfunction when they're seeing me today, either acutely or on a more chronic basis? And the answer is, you don't do anything differently. The same group that I showed you that studied vancomycin earlier studied this question and found that even when you give really high doses, there's no increased risk of kidney injury just by giving doses. So I try to keep things simple in the ED. We have a lot of things to worry about and a lot of things going on. So the first dose should really not change regardless of renal function. Subsequent doses most definitely will, but the first dose, don't think twice about it. Give the same dose that you would even if they did not have renal dysfunction, which is what I say here. So even dialysis patients, this is a thing that we see a lot of dialysis patients at my hospital, and they come in and we want to give them vancomycin for whatever infection we think that they might have. We do not change the first dose, even if they are on dialysis, because it's removed by the kidneys, of course, but we just measure levels and we'll dose based on level. And that's something that can be done on the inpatient side. And I understand that your hospital is similar to mine, where you're practicing a lot of inpatient medicine in the ED these days. I used to say that if I'm ordering vancomycin levels on someone, they've been in my ED too long, but now it's more the norm. So I don't get to make that joke too much anymore. So when is 1 gram the correct dose? Well, it's really only correct if you have an older, frail patient that is 50 kilos or less. Other than that, you should be giving them the weight-based dose that's much higher than 1 gram. And there was a study two studies actually in the Journal of Emergency Medicine that they came out in the same issue, and it was 2 groups that basically asked the same question. And they were basically saying, how many patients who get vancomycin, what percentage of them get the right dose based on the guideline? Any guesses as to what percentage of patients got the right dose? Yeah, you're close. It was 20. And most of the 20% was where 1 gram would have been the right dose. So we were doing it wrong. So how do we do it better? There's newer studies now that are saying, like, if you have access to an electronic medical record, use it. You have order sets, you can build in the doses, you can build in the weight-based doses. So you don't even have to think about it. You just choose the dose and then it calculates it based on their weight for you. And they found that using this approach actually significantly increases our chances of getting it right, and specifically so in the ED. So this is one way to go. If you look at the guidelines, so this is a snapshot of the skin and soft tissue infection guidelines from the Infectious Disease Society of America. And I circled here the 3 places on this chart where they have vancomycin. So we're going to kind of tie this back to vancomycin. They only recommend it in severe cases. Now, we see a lot of skin and soft tissue infections in our emergency departments. And most of them are in the mild to moderate range, but occasionally you'll get the patients who failed outpatient therapy and now they're back to see you. Or they have systemic signs and symptoms. They might have a fever. They might have other things that are making you think that they're sicker. Those are the patients that we should be targeting for IV vancomycin therapy. Other than that, if it's a mild or moderate case, we should be trying other things first before we jump right to vancomycin. There was a thought probably about 10 years ago now that we were seeing rising levels of community-acquired MRSA. And so what we thought was going to happen is that we were going to start needing to treat all of our skin and soft tissue infections with MRSA coverage. But it turns out that that's not actually the case. There were 2 really good studies that basically did the same thing, and they looked at cephalexin, which is just a simple first-generation cephalosporin, and with placebo, and this is just for uncomplicated skin and soft tissue infections. They looked at cephalexin versus cephalexin plus, I'm just going to use Bactrim here because it's easier to say. What's your term for sulfamethoxyl? Ceftra. We'll use Ceftra then. So cephalexin plus Ceftra. And the Ceftra was there for the MRSA coverage. And they actually found in both of these very large studies across communities that had lots of MRSA, that there was no difference in the cure rate. And so what that meant is that even in places where it's endemic, where MRSA is endemic, it doesn't mean that it's changing what you're seeing with your uncomplicated skin and soft tissue infection. So you can still get away with just using your cephalosporin if that's what you use here. So this is our approach where we are, and I changed the antibiotics a little bit to be familiar to you here. So on the left-hand side of that IDSA chart I showed you earlier is the non-purulent infections. And essentially what they're getting at is these are the strep-based infections. And if I have a strep-based infection, I'm going to give cefazolin IV or cefadroxil. Remember I said earlier that there was a couple of cephalosporins that didn't have the best bioavailability? These are some of them. And that's why I'm listing cefazolin IV here as an option, because if they're going to be staying with you in an observation capacity or something for 24 hours, it might be okay to give them some IV therapy just because we know that the availability of that is pretty good.
Cephalexin as well. I read some good cephalexin had reasonable bioavailability, not cefadroxil.
Yep. So the question was about cephalexin's bioavailability, and Will's correct is that its bioavailability is actually pretty good. However, it's dosed 4 times a day. And I don't know how you personally are about taking anything 4 times a day. I know I'm not good, and I know our patients are not great. Now, one quick trick of the trade I can tell you is if you do want to use cephalexin, instead of using 500 milligrams 4 times a day, you can actually get away with using 1,000 milligrams twice a day. And there are some older studies that support this dosing. So you can get away with trying it 2 times a day if you want to.
That saves you an IV.
It does. So strep, I'm thinking my cephalosporins. And if I do happen to use IV, that's great because now I have something oral I can convert it to if they're going to be staying with me and then going home after 24 hours or so. And then if I'm thinking about my purulent infections, that's when I'm more focused on staph. as my, and usually it's a MRSA infection, but it could just be generic Staph aureus. And that's what I'm starting to think about. I'm using my Septra or I'm using doxycycline, and both of those are very good at covering MRSA, and they're both oral, and so you can use them orally. And what we tend to do is that if they fail those therapies, that's when we would think about maybe jumping to the next one, which might be vancomycin, but we don't start with that unless we absolutely have to.
They cover strep adequately, Septra and-
Great question. So Will asked if the Septra and the Doxy cover strep also. So Septra, not that great. Doxycycline may be slightly better. So if you are concerned with the cases that might have co-infection with both, then you do need to use two therapies. But for just the uncomplicated skin and soft tissue infection, you don't. If it's purulent, maybe with a surrounding cellulitis or something, even after you've drained it, then you might want to consider using both. It's a good question. Any other questions here before we jump to the next one? Yes.
You said earlier that never do the one-time IV dose. Applies also for this context.
Yeah, good question. I'm glad you mentioned that so I can clarify a little bit. So the question was about using the one-time dose of vancomycin that we talked about earlier, and if it's okay to do it here. So the reason I recommended against it earlier is because it's a bridge to nowhere. So if I'm using a dose of vancomycin once and then I'm switching to something else, then I'm not going to get any benefit from that vancomycin. Here it's a little bit different because I'm going to be using basically an IV version of whatever I'm going to convert them to orally. So you're kind of just continuing therapy with the same thing basically. Thanks for asking that. Any other questions or comments here? Okay. Will, can you just let me know if anyone online asks anything?
Yeah.
Or thanks. Okay, so we're moving up the ladder now. We are now at Jedi Master Training. I want to talk about something that I learned when I was in school, and I'm sure those who have been practicing for a while have as well. And that is that we used to double cover for gram-negative infections, particularly things like Pseudomonas that can be pretty nasty. And the thought behind this is that the resistance is high, and so if you give them 2 antibiotics to start, hopefully one of them will work, and then you can have them empirically treated. But most of the guidelines nowadays and the newer studies suggest that you should not be doing this. There are 2 scenarios in which you still should consider double covering. One is for neutropenic patients, and the other is for septic shock with a high risk for multi-drug resistance. And so for those 2 scenarios, I wanted to kind of walk through how to do it correctly because we often do this wrong. So the way that you do it for double coverage is you pick one agent from the left column, which is your gram-positive coverage. We tend to use vancomycin as our first line at my hospital. You might use something different here. And then we're focused on the gram-negative. So column 2 in the middle are all beta-lactam-based gram-negative coverage agents. So you can choose something like piperacillin tazobactam, which has really extensive gram-negative coverage. We use cefepime a lot at my hospital. And then you have your carbapenems and aztreonam. So you get one from that column. And the reason you only get one is because they all work the same way and attack the bacterial cell wall in the same manner. And so they're not going to be offering, if you add 2 of them, they're not offering anything more than the first one did. So you pick one from that column, and then you're going to pick one from the third column. So you have your fluoroquinolones, which we'll talk about later. You have your amikacin, topramycin, your aminoglycosides, and then you have some of your like really old school gram-negative, kind of like your IV bleach type stuff. So that's how you do it if you need to. So if I had a really sick sepsis patient, I might choose vancomycin and cefepime and then gentamicin or something like that as my 3 choices. But we don't need to be doing this routinely. Now, I wanted to bring this back. In 2019, the community-acquired pneumonia guidelines in my country got updated finally after like over a decade. And they broke it down into different categories based on how sick a patient was. So they started with like outpatient, not very sick, and then kind of worked their way up. So I'm kind of in the second half of that, starting with this slide. So if I have an inpatient, someone I'm admitting for pneumonia, they're not severe, and they define severe in the guidelines. I think I might have a slide on that coming up. They have no MRSA or Pseudomonas risk factors. Then I'm going to give them a beta-lactam. We're typically going to use something like ceftriaxone at my hospital, which I know that you use here as well. And then we're going to choose either azithromycin or doxycycline as my sort of atypical coverage agent. We tend to shy away from fluoroquinolones, but they are an option based on what the guidelines will recommend to you. If we change that to a severe case, it doesn't actually change that much, except to say that if you choose a fluoroquinolone, then you have to add a beta-lactam to it, just because our resistance is increasing so much for some of the common pneumonia bugs. This is really old, but it's still what they currently recommend. So this is how I define severe cases. You have to have a couple of the minor criteria or one of the major criteria. And these are things that you're very familiar with, things that we used to define sepsis for and things like that. So this is how I determine like if it's a non-severe or a severe case of pneumonia. The biggest risk factor, we used to think that there was a lot of risk factors for resistance, like being in a dialysis clinic. There was all these things that were listed, being in a long-term care facility. The only one that really, really matters, and you have to ask your patients this or do a chart biopsy, is did they have IV antibiotics in the last 90 days? If the answer to that question is yes, then they are at a higher risk of having a multi-drug resistant organism when you see them today. The other things don't really seem to increase the risk as much as we used to think. So this is the question to ask them or to find out if you're trying to figure out if they have a risk for multi-drug resistance. Yes. Yep. So the question was, does this also apply to PO antibiotics? And the answer is no. It's just IV antibiotics. And I think the reasoning is it's IV antibiotics, but it's because they likely were sicker, and if they were getting IV antibiotics, they were probably in a hospital and so had exposures to other medications or other infections that they could increase their risk now. Okay, and then this is the final slide, which goes back to the double coverage point I was making earlier. So if you have a sick inpatient, so a severe pneumonia patient that you're admitting, and they do have MRSA or Pseudomonas risk factors, then now you're switching altogether. So instead of the beta-lactam azithromycin combination, I'm jumping to something like vancomycin. This is evidence-based from the guidelines. I'm choosing my cefepime or my piptazo or whatever. But then the double coverage piece is I'm not adding a second gram-negative coverage agent. I'm adding the atypical coverage agent. So I'm adding my azithromycin or my doxycycline, potentially my fluoroquinolone. So I'm giving my severe pneumonia patients who are getting admitted 3 antibiotics if they have risk factors from MRSA or Pseudomonas. You probably have, we call it an antibiogram in our hospital, where basically you can look and see what your susceptibility patterns generally are, just from the community. So you might be able to kind of choose your gram-negative agent based on that. Alternatively, you could look at the patient's susceptibilities if they've ever had cultures in the past. I typically look back about 6 to 12 months to see what they've had. Okay. Yeah. Sure.
Hi, it's Wayne Choi. Just a question, is ceftriaxone generally sufficient for a patient who needs to be admitted, like, or do we always just jump to piptazo for the pneumonia specifically?
Yeah, good question. So hopefully everyone online heard that as well. So if it's just a regular community-acquired pneumonia that's kind of on the more severe side that I'm admitting, and they don't have risk factors for MRSA or Pseudomonas, then ceftriaxone plus azithromycin or doxycycline is totally fine. That's what we do at my hospital. That's what you can do here as well. It's only when they're sick with those risk factors that I'm starting to jump outside of that and add my broader spectrum agents.
Thanks.
All right, we have a question in the room. Yeah, so the question in the room was, when I went back to the biggest risk factor for multi-drug resistance is IV antibiotics in the last 90 days. The question was, does it matter which antibiotic? And the answer is no, it doesn't matter which antibiotic. So any IV antibiotic in the last 90 days is a risk factor. Yep. Okay, any other questions on this? So just to summarize, double coverage, we shouldn't be doing it routinely, but you might see it in these nuanced scenarios with really sick pneumonia patients, neutropenia, or septic shock. All right, so what about dosing? Again, we're going to keep this simple. So I'm going to give you a couple of background slides and then we're going to simplify it. What we've learned over time is that patients that are sick, critically ill, that have lung infections, some of the antibiotics that we typically give, like piptazo, don't have as good of penetration as we would like. And so that's concerning, right? So that could mean that we're underdosing patients even though we don't know it. We also know that just in critically ill patients in general, they have different kinetics in how their bodies handle medications, particularly antibiotics, renal function, liver function, all those things. And so we typically underdose in critically ill patients. We also know that we underdose a lot in obese patients. And so we've already talked about kind of two main populations that we see: critically ill, obese patients that can be challenging for dosing. So here's the simplification. Remember, we're in the ED. I like to keep things simple when we can, as long as it's evidence-based. So we're going to kind of go through one by one the classes of antibiotics we talked about. So penicillins, if I don't know what drug reference you use here. But you can, we use a bunch of different drug references in our hospital, but whenever you look at some of them, you're going to see like a range. So it might say Piptazo 3.375 grams. We're just going to pause for 1 sec.
A quick question.
Sure.
We're taking our pause.
Yep.
You know, our institution, I find we throw ceftriaxone and tazocin at people like it's candy. I used to work in Vermont. I used to work in Georgia as well, and pretty similar, patterns there. How concerned are we, or should we be about, emerging resistance to these medications? And are there any other viable options that we should be considering a little bit more?
That's a great question. So the question was, particularly with things like ceftriaxone or Piptazo, like we use them a lot, and the answer, we do. Absolutely. I have a slide in a different talk that I have them like basically on draft coming out of like a beer keg because we use them so frequently. So the question is resistance, and I think back to even in just my career. So I've been doing this for about 15 years now, and I've just watched the sexually transmitted infection guidelines go from 125 milligrams of ceftriaxone to 250 to 500, and that's all because of resistance. I didn't show it in this talk, but I have a slide of azithromycin, so just Zithromax, and its resistance patterns to strep pneumonia in the US. And everywhere you look, it's over 25%, which is why we can't use it. We can't just give patients a Z-Pack and send them home anymore with pneumonia. We just can't do it anymore because our resistance is so high. So the answer to your question is yes, it is a problem. However, I will tell you on the inpatient side, we've been tracking our antibiograms over the years, and it hasn't changed as much as we would think. And so ceftriaxone is still pretty good against most of the things that we care about in the hospital. In our hospital, Zosyn or Piptazo is as well, and cefepime. So we've seen them go up and down a couple percentage points, but overall, even for the Pseudomonas and the Klebsiellas, like they're generally seem to be holding strong for now. And then there are obviously companies that are trying to develop newer antibiotics as well. And I will say too, we also have some antibiotics kind of like hidden away. They might be not on your formulary or very highly restricted that are available for those cases you're describing. So we do have a couple of things up our sleeves, so to speak. But yeah, it's concerning, and I am worried about the future of antibiotic care for sure. So for critically ill obese patients, the way that I like to think about them in the ED is if I'm looking at my drug reference, so Piptazo, it'll say something like 3.375 to 4.5 grams. Just choose the higher dose. Again, we're talking about the first dose in the ED. We're going to keep things simple. I identify someone that's critically ill, obese with severe septic shock, whatever. I'm going to give them the higher end of the dosing. For cephalosporins, for cefepime, if it says 1 or 2 grams, I'm choosing 2 grams. Carbapenem's the same, and fluoroquinolone's the same. Aminoglycosides we're not going to get into today. There's very nuanced dosing for that. If you have a pharmacist, they can help you with that. And then vancomycin we've talked about extensively already, so we're not going to get back into that today. But in general, the theme here is choose the higher end of the dosing scale if they're critically ill and or obese. The next 2 slides I'm simply putting out there just as letting you know these resources exist. So there is an actual evidence-based document guideline that's in the literature that talks about how to dose in patients who are on any sort of renal replacement therapy. So that exists out there. And then just earlier this year, before I came, as I was preparing the talk, there was a new guide for dosing in obese patients that came out as well. So again, you don't need to know these things. I just want you to know that they are out there, and there are people that are looking at this and trying to gather all the data we have so we can make the best decisions. I want to give you one quick point, and this applies to 2 of the more common gram-negative agents that we use. So we've gotten better in the ED space of identifying sick patients and getting the first dose of antibiotics on board early. I think there's literature to support that. The problem now is coming into play with subsequent doses because they're continuing to stay in our EDs for much longer. They might still be under your care before their care gets transferred to an inpatient physician team. And so we need to remember kind of to redose. And there's a problem here. So I don't know how your practice is exactly, but when we see a patient in the ED, our whole team goes to see them together. Physician, pharmacists, nurses, we're all together. We get the patient started, do the interview, do the physical exam, vital signs, all those things, get IV access. And if we identify them as being sick, we're going to put orders for medications in right then in the room. And at that time, we rarely have labs back. So I don't know what their renal function is. I don't know what their liver function is, anything that I care about for dosing. So that's fine. I give them a one-time dose of antibiotics, we're covered, but then I have to remember later to go back and redose them. The other alternative is that if I order it as a scheduled dosing, so cefepime Q8 hours, now when the labs come back and the creatinine is, actually I don't know what your units are. The creatinine is very high. Now I have to remember to go back and change whatever dosing I put in earlier because it's not compatible with this creatinine value that I have. So neither one is ideal. And I don't know which way you generally do it. We do it as the one-time dose approach generally. So there was actually a study in Critical Care Medicine, the journal, that found that our second doses are delayed about 75% of the time, which makes sense to me based on how complicated it can be to do this. So I just want to make you aware today that the first doses we're better at, but the second doses we're not as good at. So just kind of keep that in your mind. We actually developed a practice using our electronic medical record at Mass General Hospital that it'll fire silent alerts in the background. And then when it's time to actually reorder, it'll actually show you like, hey, it's time. It's kind of within the range of when you would normally want to reorder this medication. And we did that specifically for these 2 antibiotics. So we're gonna see how that does. All right, the very last thing I want to talk about, and we'll wrap up this talk for the day and take a quick break, is previous cultures. We kind of talked about this earlier. We have a wealth of knowledge available to us now electronically that we didn't have before. It was just in paper charts. In my hospital, we're part of a big hospital system. So mine's the biggest hospital, but we have 13 hospitals as our system, and we're all on the same record. So if a patient goes to any of the hospitals in my system, I can see all of that information, including primary care. And then we also have ability to tap into other systems, hospital systems that use our same electronic medical record and look at that. So I can look at most of the data that I need to make decisions on patients in the ED, which is great. One of the things to remember is what we do matters. And I know you know that, but I want to reinforce that to you today. It matters. The antibiotic choices we make in the ED, I know a lot of times anecdotally, it seems like they always just DC them all and write something different in the ICU. But in reality, when they study this, most of what we order is continued on the inpatient side. So the decisions we make actually do matter for continued care upstairs. And they found that adequate antibiotic coverage prior to the ICU is a predictor of mortality in some cases, particularly with the sepsis ones. So making the right choice matters early on. So what I do, my practice is that if I have it available, I'm going to look about 6 months back for culture data. Beyond that is not super helpful to you. I know it sometimes can be enticing to be like, oh, 4 years ago they had this Klebsiella infection, but that probably is not what you're seeing today. So I generally look at about 6, maybe 9 or 12 months at a max, just to see what they've had. If they've had a resistant E. coli or Pseudomonas, then I'm going to tailor my therapy today based on that recent culture. But beyond that, I'm just going to kind of do more generically to cover them broadly. Yes.
Is it 6 months of data of the same source? So urine for urine,
Yep.
lung for lung? Or?
Good question. So the question was, is it 6 months of data just from the same source? So I'm just looking at all the urines. What if they had a wound culture? I'm looking at 6 months of all of it because generally beyond that time frame, it's just different bugs that would be growing. So if it's a wound culture I'm looking at today, I'm going to look back largely at the wound stuff. If it's if it's a urine culture, I'm generally going to look back at urine, maybe blood for related things, anything that's related. Great question. Okay, so to summarize this part of the talk, cross-reactivity between cephalosporins, penicillins, carbapenems, not a big deal. Just remember that there is that side chain issue And so if you have like an ampicillin or amoxicillin allergy, you might run into some issues with a few specific ones. The oral route is good for most patients, so don't always just jump to IV because you think it's what you have to do. You don't always have to do that. For your first dose of antibiotics, always go high, particularly for your critically ill patients. We can adjust later, but it's important to get them loaded up. You saw, remember, vancomycin, even we give those whopping doses, the levels don't get very high. And then local/patient susceptibilities are important. So look back at about 6 months of data if you have it available to you to make your decisions. All right, yes.
Great talk, thank you very much.
Thanks.
I have 2 questions. First is, I like the simple approach. So arrive at the patient with a septic picture. I'm concerned about the one of your antibiotics. Is there any antibiotic that I can't use empirically one time before getting labs? So forgetting renal function, potassium, any drug that I can't just give them the initial dose, full dose, or do I have to think about certain antibiotics?
Yep, that's a great question. So going along with the simplification scheme are there any antibiotics we shouldn't be using as that one time, even before we have labs? And there actually aren't. No, you can, whatever you think is the right thing is okay. There's really none that are off limits.
Great, that's simple. The second question, any comments on rapid antibiotic administration with push dose antibiotics?
Yeah, great question. So rapid administration, push dose. So we were forced to do that in a way a couple of years ago. I forget which hurricane it was, but one of the hurricanes hit Puerto Rico, and it shut down a lot of our fluid supply. And so a lot of the fluids that we would mix antibiotics in, we didn't have. And so we were forced to change some of our practices, particularly things like ceftriaxone in the emergency department to IV push rather than in an IV bag. I mean, we've kept it, since that time. That was 4 or 5 years ago now. We've kept it. So there is an advantage to using longer duration of infusions for some antibiotics. So I don't want to say move to IV push for everything, but for non-CNS infection, so kind of anything below the brain, you usually can do it for things like your cephalosporins and some of your penicillins as well. Yeah. So we have basically the answer to your question, my hospital is we have a mix. Some of them we do IV push, some of them we still do as an IV infusion. Yeah. Oh, you brought up a great point. I was hoping no one would mention that. So the question was, I mentioned earlier that we use our electronic medical record for the dosing. And so for example, I'll choose my sepsis order set and it'll kind of have all the labs that you would like to order. And then it'll have my antibiotic choices and I'll pick like vancomycin 20 mg per kilo or whatever. And then I kind of hit send and then it goes off into the ether and you hope that it happens to the patient, right? So the question is, what happens when you don't have a weight? And we don't have a great way of dealing with this in my hospital. It often tends to be either asking the patient if they can tell you, which is even then is not always helpful. We don't have scales on all of our beds except for our stroke neurology bed that we bring right to the CT scan. That's kind of the only like weighing scale bed we have in the ED. So oftentimes it's a conversation between usually the pharmacist. They always think that the pharmacist is good at guessing weight. I don't know why we're better than anyone else at guessing weights. But we usually will kind of estimate for the first one if we can't get an accurate weight, and then we'll make sure we write a note to make sure that weight gets updated when they get upstairs. But we don't have a great solution to that problem. It's a good one.
But we have so many wait times. The wait time is so long. We think that we could use that time to wait patients, vaccinate them, maybe educate them about nutrition. Like, why don't we use that time and do something useful for our patients?
I can't disagree with you. When I was back at my first hospital, the University of Maryland, we actually gave patients a form to fill out while they were in the waiting room for many hours to get basically to do their med histories for us while they were in the waiting room, because like, you're not doing anything else. So can you help us out and write down all your medications for us? So yeah, I do think there's a better use of waiting room time for sure. For sure. Thank you. Yes.
I just want to ask, so when you made a point about when you go into a room, there's a physician, a nurse, and a pharmacist. Is that for every patient or the patients who are under their critical care leaves?
Yep, that's a good question. So our ED we see about 120,000 patients per year. So I think it's like 400-ish a day about. We have our ED broken up to many different areas, probably like you do. And so the pharmacist is situated, we're kind of caring in a sense for all the patients, but we're situated in the acute area, which is the higher acuity area. So those are the patients that we're actually going to the bedside for.
Would you advocate, we used to have, and I know there's some pharmacists in the room here, would you advocate that, for every critical care patient, we have a resuscitation room with six beds, that, whenever a new patient comes in, perhaps it'd be a bit more of a unified team approach, because I would probably say that pharmacists might be a little bit more current in terms of, hey, maybe we should be using this antibiotic as opposed to this, let's use this dose. So would you advocate that pharmacy is a little bit more involved in some of the more critical care cases?
Yeah, I would. And I certainly don't want to advocate for more meetings for anyone, but I do feel like it's valuable when multidisciplinary teams are approaching these problems before it's like in the ED. So your quality and safety group meetings, your safety meetings, whatever those look like here, to make sure there is a pharmacist and nursing and all the kind of major groups on those meetings. And that way, when you're developing new protocols or pathways or approaches to treating sepsis patients, there's input from all the right parties, even if they can't physically be there when it's happening necessarily, because I don't know where your resources are here for pharmacy or whatnot. But so I would recommend that they be available for those groups, those committees that meet to kind of plan that stuff out.
As you're kind of scaring me away from one dose IV antibiotics, I've moved a little bit more towards my patient happens to have an IV if I'm treating a possible STI. Should just give ceftriaxone IV instead of IM to save them the jab in the arm. Would I be better off not doing that?
Yeah, that's a great question. So when I got my kind of how Will found me in a weird way is I just happened to, when I finished my toxicology fellowship at the University of Maryland, I got my first job as an ED pharmacist at the hospital that was attached. And I was there for 8 years, and I just happened to be in an ED where people like Amal Mathieu and these famous like ED clinicians practice. I didn't know who they were. I just happened to land there. And Haney Malamet, who does a lot of ultrasound and critical care stuff. And so when I got there, I honestly, I wasn't on Twitter. I didn't do anything related to that stuff. And I thought it was for like following Justin Bieber, which I had no interest in. And so, but they kind of showed me that there was a lot of emergency medicine and critical care education happening in these social media spaces, even back in the early 2010s. And so I started just kind of posting daily pearls about just random drug things that I would kind of basically questions I would get from residents a lot. And so I would post those, and it kind of led to me working with Michelle Lynn on the Academic Life and Emergency Medicine blog team. And one of my very first posts that I ever did was exactly your question. So I was like, this doesn't make any sense. Why are we doing this? Because I'd always heard about this depot effect of ceftriaxone IM and that it lasted this long period of time. And that's why we're using it for sexually transmitted infections. And it turns out that when you look at the kinetics, it's actually not true. The IV dosing, it gives a pretty similar profile kinetically to the IM. And more recently, there's actually legitimate data to support this outside of just the kinetics. There was a study in China or Japan or somewhere with actually like this was their practice, and they did fine. So there's actually evidence and kinetics to back up that if your patient already has an IV, that you can give them the dose of ceftriaxone IV. Now, the dosing part is tricky because a lot of our ceftriaxone dosing comes in like standard bags like the IV. The IM you can just kind of mix however you want and inject it. But so we tend to still do like a gram IV. I know that's not technically the same. It's 500 if you're doing an IM. But the answer to your question is yes, you can do it IV. We use a gram when we do it that way at my hospital. Yep. Awesome. All right.
Maybe, I'm not sure if we'll take a break now or after the next one. Usually put around
The next talk will be about 35 minutes or so. Okay. All right, let's see if we can make this work. I don't read French. Can you help me? I'm trying. All right, are those online? Can you see my new slides? It says drugs with FDA box warnings.
It is not in full screen mode. It was like what it was before.
We're back to the same problem. Okay. How about now?
No change.
No change. Great. Can you show me how to do that? Awesome, thank you.
It's working.
All right, how
It's
about
good.
now? Okay, awesome, thank you. All right, so we're going to switch it up. The 4 talks I'm going to give today are all related to medications, obviously, but they're very different in their themes. So hopefully you'll get some pearls from each of them as we move forward. So this was part of a talk that I originally gave at ASAP a couple of years ago, but it's morphed over the years. And so in the U.S., obviously we have the FDA, and they function as, they do a lot of things, and we don't believe anything they say anymore. Just kidding. So they do a lot of things, but the primary role is keeping us safe from medication. So their whole job is to determine the efficacy and safety of medications before they get approved for use in humans, basically. So they review thousands of documents that are submitted by drug companies, and then they make these decisions. And what they have available afterwards is, so you as a practicing physician, if you were to identify a potential side effect or a risk of a drug, you can go online to an FDA site and you can submit this. It's not peer reviewed. You can literally write whatever you want. You don't even have to be a physician to do it. But you can submit these to the FDA, and they review these and they identify signals of harm. And if they identify enough signals, then they'll issue different types of warnings. And one of the warnings that they put out there is it used to be called the Black Box Warning, and I'll show you why that was in a second. It's now just called the Boxed Warning. And it's not necessarily a contraindication. It doesn't mean you can't use the drug. It just means that in a particular type of patient or scenario, the harms may outweigh the benefits. So the reason that it was called a black box warning is on every drug that we have at the pharmacy, it comes in obviously the bottle, and there's a package insert that's this really long, very small font document. And if there's a boxed warning, it's literally in a black box, and that's why it got that nomenclature. And so this is one that I'm highlighting here for fluoroquinolones, which we'll talk about in a few minutes, but this is kind of what it looks like. And the reason I think it's important to talk about this is that a group a couple of years ago looked at how often we as emergency clinicians consider boxed warnings when we're prescribing medications, and the answer is not that often, only about 37% of the time. So I think it's important to highlight some of the ones that you should care about, so that way you can make informed decisions when you're prescribing. So we're going to talk about 4 different drugs or drug classes in this talk, and hopefully you'll learn something that you didn't know beforehand. If you've heard anything that I've said or written, you probably know that I'm not a big fan of fluoroquinolones. In fact, they are my least favorite class of antibiotics. Ceftriaxone is actually my favorite, so I hope it doesn't go away. But fluoroquinolones are my least favorite. I'm going to kind of share with you why right now. So there are 4 different boxed warnings associated with fluoroquinolones, and that's a lot. Most drugs have one if they have any. And the one that you are probably most familiar with is the tendon rupture one. The risk in general, in the general population, is about 4-fold higher than other antibiotics. And if you were to add in 2 factors of being elderly and on steroids, the risk is about 40 times higher. And so for those patients, I'm thinking of patients that maybe have COPD exacerbation, and I might be giving them steroids and a fluoroquinolone antibiotic or something like that. We care about it most, or the biggest risk is in the Achilles tendon. And what I'm concerned about also is that this risk continues even after you finish the antibiotic. It can continue for up to a couple of weeks. So just stopping the antibiotic doesn't necessarily sort of fix the problem right away. Kind of putting this in more general terms, about 1 in 6,000 patients who are prescribed fluoroquinolones will develop an Achilles tear. And if you're on steroids, it's about 1 in 4,000. So you may be thinking in this room like, oh, I'm never going to prescribe 6,000 courses. And you're right, you won't. But if you think about everyone here together collectively, or just emergency medicine practice, we can get to that number quite quickly. The second one is related to neuropsychiatric effects in seizures. So when in America, pharmacists that want to pursue postgraduate training can. It's not mandatory, but it's voluntary. So you can do a first year of residency, which is kind of like a first year of residency for a physician where it's kind of general. You're rotating through many different units just to kind of get a general sense of practicing as a pharmacist with the teams on the floor in a clinical setting. And then if you want to specialize, then you go on to do additional years. So I did 2 years of toxicology fellowship afterwards. But one of my very first rotations as a first year pharmacy resident in the hospital was in a surgical ICU. And we had a patient who had been there for a couple of days and did not have a history of seizures, and all of a sudden developed seizures. She had 2 within a 24-hour period. And it turned out that over the course of a couple of days, her renal function had started to decline, and she had been on levofloxacin. I don't remember exactly why. And so what had happened is that the levels in her body had started to build up over those times when it wasn't getting eliminated properly. And that caused her actually to have seizures. And when we discontinued that, it actually fixed her problem. So that's something that'll kind of stick with me forever, but that actually has a boxed warning.
Right, is that only that toxic, toxic levels, or is that therapeutic dosing?
Yep, that's a great question. So the question was, is that related to just toxic levels or at baseline? And in general, if you're just taking at therapeutic doses without the renal dysfunction issue, you should be okay. The risk is relatively low. As you probably are aware, pretty much no antibiotics are safe with myasthenia gravis patients, but fluoroquinolones in particular, along with aminoglycosides, are at the top of the list of drugs to avoid in myasthenia patients. So that has a boxed warning. And then the fourth is peripheral neuropathy. And what's concerning about this is that this can be permanent. It's actually been recorded in a couple of case reports. So if they develop peripheral neuropathy, it may not actually go away. So you may be thinking to yourself, like, okay, Bryan just presented 4 boxed warnings. They're all pretty bad, but in general, the risk is low. So that's probably not going to necessarily dissuade me from prescribing fluoroquinolones. That's fine. I understand. I respect that. So what I want to do now is I want to talk to you about all of the other side effects that come along with fluoroquinolones, because I think if we want to be educated about this, we need to think about it holistically. Out of all the antibiotics, they have the largest risk of QT prolongation, which again, in many patients, I may not care about a small risk of QT prolongation, but if I have patients that are on methadone or other drugs that could prolong the QT, then this can be problematic. Moxifloxacin has the highest risk, and it's higher than azithromycin, which you're probably aware of. Second to clindamycin. Fluoroquinolones have the highest risk of causing C. diff, so just keep that on your radar as well. Third, they actually seem to cause injury to the aorta. Again, the risk is overall pretty low, but this kind of combined with the other risks can be problematic. Sorry about that. The risk is about 2.5 times higher than non-fluoroquinolone antibiotics.
Is that for people only who already have an aneurysm, maybe dissection, or de novo?
It can be both de novo or a worsening of a pre-existing injury. Now, I say that we don't often know if patients have a pre-existing injury, so it could be all the former. And it's the highest risk is in older adults over 65. Third is it can actually mess with your glucose levels, and this is in diabetics and non-diabetics, and can lead to an increased risk of hospitalization. So just be aware of that as well. And fourth is retinal detachment compared to other antibiotics. And this is one I've not actually seen this in practice, but the risk is actually higher than some of the other side effects I told you about. So where do we use this? So again, I don't know exactly how your EDs are structured, but we have ours. We have our main ED. We have an ED observation unit. So that's like a separate group of nurses and physicians that are ED practitioners that are taking care of the patients for the next 24 hours. We have our inpatient boarders that I know you have, and then we have discharge prescriptions for patients that come to see us and then go home. So fluoroquinolones are kind of ubiquitous, and they're used in all 4 of these different patient populations, which means that they're kind of spread across a lot of different patients. The FDA put out a notice in 2018, which I agree with, which is that for these 3 indications, you should only be prescribing fluoroquinolones if there are no alternatives. I would actually extend this to pretty much all infections. And what does no alternatives mean? Well, I think about things like if they've failed other therapies, or they have resistance to other things and fluoroquinolones are their choice to use, or they have legitimate allergies that I can't use my first or second line therapy, that's when I'm thinking about using fluoroquinolones. Other than that, I'm generally not using them. And I didn't even mention that the resistance is increasing. So that's just another reason that you might think about avoiding them. So in general, my judgment for fluoroquinolones is that we tend to avoid them at all costs unless we absolutely need to use them. So I don't know, what are your thoughts on fluoroquinolones? Do you use them here?
So,
You love them?
I do try to avoid them. Sorry.
I heard someone say they love them, so.
I love their simplicity. I love one time a day,
That's true.
Sit 750 for 5 days.
It's true.
Yeah, it just, they're simple. I get what you're saying. It will change my practice, but like intuitively, they're very convenient to try.
The problems are that I see people do the 750 for 7 days. They don't understand that it's also supposed to be a shorter duration. I also see people giving it, it's still common for uncomplicated cystitis, in some people's practice. The other question I have is prostatitis. For me, it's the best absorbed drug in the prostate.
It is.
And even though I think we probably overcall prostatitis, I think in general, I mean, am I supposed to give someone 6 weeks of Ceftra, which has its own problems, or do I give them a beta-lactam? So what is recommended in your hospital for prostatitis?
You mentioned kind of the one or two sources of infection that I think that there's still a pretty good reason to use them. Oh yeah, sorry. The question was about its use in prostatitis. So I think for urinary tract infections and for prostatitis, they still would be on my list. Definitely prostatitis. To me, those are still kind of first line. For UTIs, we tend to use, for the uncomplicated ones, nitrofurantoin is pretty good in the US, which has a pretty lower risk of side effects. However, E. coli is still pretty susceptible to fluoroquinolones where we are. So you could use them, but we tend to use nitrofurantoin as our first line. Okay, awesome. All right, number 2. This one's not going to surprise you too if you've been on social media ever in the past 10 years and looked at EM medical literature. But my next one I want to talk about is tramadol. So I promised you one structure. I forgot I had this one in there. So this is the second. Doesn't mean anything. You don't even need to care what's on there. But tramadol has 8 boxed warnings. So I think it wins the gold medal for most boxed warnings out of any drug, actually. And if you look at them, which I'll show you in a second, you're going to see that they look a lot like opioids. And they should, because we often think of tramadol as a healthy alternative to opioids, I guess. But it actually is an opioid. I think we forget that. We're kind of thinking about what's an alternative that I can use that's not like as strong as morphine or hydrocodone or something, but tramadol is an opioid and we have to remember that. And so a lot of the risks are the same as they would be with other opioids. And these are some of the boxed warnings that are on there. So respiratory depression, accidental ingestion, neonatal abstinence syndrome, and use with concomitant benzos. But then the 3 in the bottom, these are very much the same as any opioid that you would see, which is the abuse, dependence, and withdrawal perspectives. So a lot of the risks associated with tramadol that we don't often think about because we think it's a weaker drug, they're actually the same, and people have bad outcomes from using tramadol. The reason why I care about this is that when I give someone morphine, for example, or oxycodone, I know the risks, but I also know exactly how it's working. I know it's binding to mu receptors. I know it's kind of working through the pain pathway that way. When I'm giving tramadol, I can't be so confident. It's dependent on patient's metabolism. And I'm only going to mention this one time. It's the CYP2D6 enzyme that we're talking about, the cytochrome enzyme. And everyone in this room has a different, that enzyme family functions differently based on your genetics. And we can't predict how that's going to work. So some patients, you give them tramadol, and tramadol has some effect, but it also has some active metabolites. And some of us are going to metabolize it normally and we'll get the benefit that was originally intended with tramadol. Some of us are going to get a much more exaggerated effect and prolonged effect. And some of us are going to get no effect at all if we metabolize it rapidly and it's gone. And we can't really predict that without sort of genetic testing ahead of time, which is obviously not practical for us here.
Cody,
It's the same enzyme as codeine. Yep, that's exactly right. So I can't predict what I'm getting with it. And then it's not just an opioid. So the other ones to be described are just opioids. This one also has some serotonin uptake inhibitor activity also. So you're kind of getting like an antidepressant in an opioid that I can't predict all in one, which is not how I like to pick my drugs. There's also a very real seizure risk with tramadol. I'll never forget this. One day when I was at Maryland, I walked in one morning and in rounds, we had 3 patients in 3 consecutive rooms, unrelated to each other, didn't even know each other, that had all in different manners had tramadol and were presenting with seizures. Now, that was uncommon. I realized things don't always happen that way in real life, but that day it did, and just kind of drove home the point. And there's actually been a couple of papers looking at the increased risk of seizures with tramadol. So does that mean I shouldn't prescribe it to anyone? No. But if a patient has seizures at baseline, I'm definitely going to think twice about it. And obviously, the higher the dose you go, the more likely they are to have a seizure. So definitely be careful of that. But there's some other things too. It's kind of like fluoroquinolones, where there's like the one thing, but then there's all these other things. And it causes hyponatremia that leads to hospitalizations. It causes hypoglycemia that also leads to hospitalizations. It can cause serotonin toxicity, though rare. And there's actually a paper that came out in JAMA like 1 or 2 years ago now that actually linked it to mortality in older adults. So we'll have to see if there's anything to that. So I'm kind of looking at tramadol as a whole and thinking like, well, it has the boxed warning for 8 different things. It is an opioid. I can't predict how it's going to work necessarily. And it has all of these other side effects. So where is it kind of falling in my pathway? So then I look at the data and I say, does it actually work? Like, what does the data say, particularly for ED patients? And there's a couple of Annals papers and Cochrane reviews that have studied this over the last decade and a half or so. And for osteoarthritis, they found that it has modest benefit. For neuropathic pain, it found that it's comparable to the other options we have, like the gabapentins of the world. For ankle pain or sprains, it was equivalent to hydrocodone and acetaminophen. Now, I'm also not going to claim that they compare this to the right things. I'm just telling you what the data is. And then for musculoskeletal pain, it was less effective than hydrocodone and acetaminophen. So I'm looking at this, and none of these are going to say like, oh, that doesn't work. But I know for certain that in some patients it won't work based on the metabolism. And I know that there are alternatives that could be a little bit safer. So if I'm going to prescribe an opioid, and I know we're in an environment now where we're trying to avoid opioids in most patients, I'm going to choose something other than tramadol first. If I want an opioid, I'm going to choose a true opioid that I know how the patient is going to respond when I give them that medication. We tend to use either morphine orally or oxycodone because it doesn't have the acetaminophen component in addition to it. So patients are less likely to get confused, and then they can take acetaminophen on the side if they need to. But we tend to avoid using tramadol for all the reasons that we described here today. Where do we use this? Again, this is pretty ubiquitous, or could be ubiquitous if we wanted it to be, kind of like the fluoroquinolones. The only place we're not using this is in our main ED, just because they're generally sicker and getting IV opioids if they need it. So my summary on tramadol is similar. So I've presented fluoroquinolones and tramadol so far, and both of them I'm kind of recommending to use alternatives if you can for most things. I promise we're going to turn around in the second half of the talk, and I'm actually going to recommend the things. Yes.
Can you give me suggestions about the Antidote, the newer version?
We haven't used it yet, actually. Do you have it here? Are you using it?
I've heard about it. I've never used it.
Yeah, we haven't used it yet either. The tapentadol, it's like a newer version of it. There's a couple of newer ones coming out, but we actually don't use that one. Yes. Yep. Yeah, that's a great question. So the question was, what about patients that have had it before and it worked for them? So you brought up 2 things that I'd like to comment on. The first is the Poison Center papers. So I did my training in a Poison Center. I think you all get to do a rotation at Poison Center, right, in New York? That's awesome. You guys enjoy that very much. The Poison Center data is great. It's the national data, and it's similar in Europe that it is to the US and Canada. It's not great for the way that it's set up. It's not good for detecting signals of adverse effects from medications. So I don't think that we can rely on Poison Center data to answer that question about how safe it is. That being said, you brought up the one patient population that I think it can be very helpful in, and that's those who have had it before and it worked for them. Because theoretically, if it worked for them, then their metabolism is such that the drug should be good for them, and we know that it worked. So we do recommend it for patients that have had it before, if they've had good luck with it. So I agree with that. Yep. Awesome. Okay. So when I first started practicing emergency medicine after fellowship, it was 2008. And we had this drug called droperidol available to us. Do you have it here? You don't have it? Oh my gosh. Well, I'm going to teach you about it because you should have it and you should get it. But it actually relates to haloperidol also. So we'll talk through this anyway. So in 2008, we had it, and it was an amazing drug. I'd never used it before. And then it went away for like a decade. It was on shortage. The company stopped making it, whatever. We just didn't have it. And then it came back. The reason I'm bringing it up here today is that it has some boxed warnings associated with it from the FDA. This is what we use it for. It's very similar to haloperidol, actually. So you can use it for nausea and vomiting, for migraines, for agitation, which is really great, and for cannabinoid hyperemesis syndrome. You guys seen that here? Yeah. So this is a great drug for that. So I'm sorry you don't have it, because it would be helpful for your patients. We think so, yeah, anecdotally. So the boxed warning is that they were concerned about Torsade, is really where it came from. And I'll kind of present that to you in a second. So even if you don't have this, I think it's important to understand how this whole system works. So I mentioned earlier that you, as a physician, if you identify a potential effect, you can go to the FDA's site and kind of submit a report. So what they did is over a 4-year period, there was almost 300 cases that were reported to the FDA, with a bunch of cardiac events and a bunch of deaths also. And this is what kind of signaled them to say, oh my gosh, what's going on with this drug? We should do something, or at least investigate this further. So they put a boxed warning on it. And that kind of led to as you can imagine, a plummet in its use in emergency departments, or anywhere. And then it went on shortage. However, there was a group of pharmacy folks, and then there was a separate anesthesiology group that I'll show you in a minute that basically said, like, let's look at these reports in more detail. So they asked the FDA to send them all the cases. And they looked at them, and they found that after they removed all the duplicates, there was only about 65 cases of the 270, whatever. And only 2 of them where there was possible evidence of harm from the actual drug. So we've gone from 300 down to like 2 where there may have actually been a problem. A separate group looked at OR cases, so that it's used in the OR for post-op nausea and vomiting as well. And they found that there were 10 that were 10 potential cases, 2 deaths. But then when they looked at those cases in detail, they found no cause and effect. So there was this kind of like, well, there's this boxed warning. We're not using it. We don't have it. There's some studies that say it might be safe. So where do we land on this? This is what's funny. So at the Mayo Clinic, somehow, when no one else in the United States had droperidol, they had tons of it. So I think that's why the shortage happened. So what they did is, over the 10-year period when no one had it, they published the data on what they did with it for the 10-year period. And they used it in almost 7,000 visits. And they used it for everything: pain, sedation, nausea, headache. And out of all those patients, they had 0 deaths and 0 dysrhythmias reported. Now, all those like reviews of the FDA cases, that's all good to me, but this is real world data in multiple conditions, multiple doses. This is what I care about. So I thought this was a really helpful paper to kind of put this kind of to bed. And if you look at all of the papers, you'll find that most of them support what this said. So the one, let's see. So the one on the top is the one that I just mentioned to you. And out of the 6,000 cases, there were 0. And when they did measure a pre and post QTC interval, it was 0.7. When they measured the QTC interval, only less than 1% had it over 500. So it was very low incidence of causing any issues there. A Cole paper, there was 16,000 patients, a very small mean increase. So basically, when you take this together, there's almost 30,000 patients in the ED multiple indications, and there was one case of torsade. And ironically, or coincidentally, I need to talk to this guy about this actually. I know John Cole. They re-gave that person droperidol. I'm not sure that I would do that. And they did okay. So that one case when they re-challenged them, again, I don't know the circumstances of that. They did not develop it. So take that for what it's worth. But other than that one case, there was no cases of torsade. So this is real world emergency medicine experience, which is what I care about. And I think that this tells us that this drug is safe. When should we care? And this is related to any QTC prolonging medications, electrolyte abnormalities, other QT meds, cardiac disease, and increased age are all risk factors for worsening the effect. We use this in the ED. So I guess I'll summarize by saying back in 2015, there was a position statement by the American Academy of Emergency Medicine that basically said, and that was before all those studies I just showed you, that basically looked at all the data up to that time and found that it was effective and safe, and that we don't even need to necessarily get EKGs in everybody prior, as long as the dose is less than 2.5 milligrams. So man, I hope you have this, get this drug at some point. It is really, really good for a lot of conditions. Go ahead. Yep. The question was, what is the advantage of droperidol versus haloperidol, which is what you have here, which we have too. And like you mentioned, it can be used for most of the same things, honestly. What we found with, actually, I'm gonna hold that question for 1 second. I'm gonna show you in a second. I'm gonna come back to that related to agitation, and I'll tie it back in. So the way that we dose it is with anything. You can always start low and add to it, except for agitation, which we use a higher dose. This is what I wanted to get back to. So this answers the question that was just posed. This is why we prefer droperidol to haloperidol for certain conditions. So I wanted to tie this into the treatment of acute agitation. And this is probably more relatable to what you do here. There are a lot of things we have available to us, but when you're in the moment and you have a very agitated patient that you need to control quickly, not a lot of the medications that we want to give intramuscularly actually act as quickly as we think that they do. And when you look at all of the data out there, ketamine is the fastest acting of all of the intramuscular medications, but not too far behind it is droperidol. Midazolam is close, and then you get into your olanzapines, your antipsychotics, and haloperidol. Look at the very bottom. So haloperidol actually takes at least 20 minutes, if not longer, to start working. Now, I know anecdotally you probably had cases where haloperidol seemed to work quickly. It may have, that's fine. This is a range, and every patient is a little bit different. But what we tend to do is we tend to give a dose, and this could be haloperidol or anything, and then it doesn't work in the time that we want it to work. And so we redose them. And then all of a sudden, 30 minutes later, they're like zonked out. And now they're zonked out for a long time. So we used to use haloperidol and lorazepam a lot. We still do. But if you redose that, now you're talking about like you're running into disposition issues, because they're just like seeping on a stretcher now for the next like 6 to 12 hours. You can't like do a physical exam. You can't really evaluate them. Your psychiatric team maybe can't do their exam on them if that's what the next step in their care is. So we prefer droperidol to haloperidol for agitation because it works quicker, and the key is that it lasts a lot less time. And so you're able to evaluate the patient again sooner. That being said, for some of the other indications like cannabinoid hyperemesis syndrome, you might want it to last longer, and that's an okay thing. So there are advantages and disadvantages. A lot of it is related to how quickly it works and how quickly it goes away. Go ahead, Joel.
Just to add to the comment, I mean, I know all of you know Ruben Strayer, who was a graduate of our program. He's an expert in agitation and the drugs to use. He basically said the same thing. You give Haldol 5 milligrams, you wait 5 minutes, and they're still thrashing about, so you give more. And then, I mean, he's such a proponent of droperidol, and we actually, I've spoken to our pharmacists because I really want to get it for the use of the acutely agitated patient. We have to go to Health Canada, get an exemption for its use. It's basically the same thing as you trying to go to the FDA and trying to, on your own, try to get an exemption for its use for a certain indication. Very complicated.
Yeah, that doesn't sound great. Yes.
I'm concerned about the FDA situation. Like they cannot remove the double cases. That's very concerning. About all the other drugs.
Well, that's a good philosophical question. So the question was, if when we reviewed the data and there were all those duplicates, does that mean that the same thing is happening for other medications that have FDA box warnings? And the answer to your question is probably yes. So this was only because folks requested all of the cases from the FDA, which you could do for anything, and then, you know, painstakingly went through all of them and removed the duplicates and things like that, and then published what they had. But yeah, it's a voluntary system that is not peer reviewed. And so, you know, that's why we still use a lot of the medications that have boxed warnings, because we know that, and we just weigh the risks and the benefits on each case. And if it makes sense, then we do it. And we'll put pathways or guidelines in place to guide us at the hospital. But yeah, you're absolutely right, that the data cannot be relied upon like you would hope. Yep. Awesome. Okay. So if you get it ever, use it. It's a great drug. I'm going to talk about a related question, which is not the boxed warning stuff, but it's a question that I get often as a pharmacist, in that what is the QT prolongation risk of the other antiemetics that we use, because we use antibiotics a lot. And so I'm going to talk about a couple that we use commonly. What I thought was interesting, though, is 15%, I'm going to get this fact wrong, but the three drugs here, azithromycin, diphenhydramine, ondansetron, those are like the top three QT prolonging meds that we use, I guess, in the ED, and up to 15% of visits contain at least one of these medications. That's what it is, which is a lot. So I'm going to walk through a couple of the ones that we use. Metoclopramide is one. I'm not going to claim it's the best antiemetic. There's kind of like specific indications you might use this for, but the risk from a QT perspective is actually quite low. And so if that's a problem for me, or I have someone who has QT prolongation at baseline, this is one that I might consider. Prochlorperazine is another one, and we love this drug, particularly for migraine headaches. It's actually quite nice. This one has minimal risk of QT prolongation as well. But the one I think you actually care about is ondansetron. We use this all the time in the ED, and every once in a while there's a study that gets published that I look at it and I think, man, I wish I would have thought of that idea. And so a couple of groups basically brought patients who were coming to the ED. They needed ondansetron. They got an EKG before, they gave them the dose, and then they got an EKG after and measured the difference in the QT interval. Brilliant. I know it's not complicated, but sometimes you don't need to be to get studies that are helpful and published. And as you can see here, the top study looked at just ED patients in adults, 4 milligram dose, and the mean QTC increase was about 20 milliseconds. A separate group looked at patients, I think, that were in the cardiac catheterization lab, but they had actual cardiac disease and QT risk factors, and theirs was about the same. And then two groups looked at pediatric patients, and both found a pretty minimal risk of QT prolongation. So what do I take away from all of this? Well, what I take away from this is that I'm not withholding ondansetron because of its QT risk, essentially. Now, if I have a patient, again, who's on multiple drugs that cause QT prolongation, or they have really severe vomiting that's causing electroidal abnormalities, I'm going to try and correct those things first, and I might choose something different. But I don't think that we need to be stopping to get an EKG every time just because we want to give ondansetron. And there's actually ASAP guidance to support that statement. Go ahead.
I think I looked into it at some point, that the recommended way to give ondansetron is like a 20-minute infusion. I've never seen anything. Does it matter which way you're giving it, whether it's...
That's a great question. So he had read that giving it over a longer period might reduce the risk. I read that too. We do not do that. We give it over the fastest IV push possible. So no, we don't. Yes.
I mean, as a times one, does it really matter anyways? I mean, how long is the QTC gonna prolong?
Yep. Usually it's just a couple of hours. So the question was, how long does a QT interval remain prolonged after a dose? And it's usually about 3 or 4 hours, which is about the dosing interval anyway. And I will tell you, one drug that I know doesn't cause QT prolongation that may work for your nausea is sniffing your isopropyl alcohol wipes. So that's another option as well. Go ahead.
So I appreciate this data about QTC prolongation, but to me, that's obviously a patient-centered outcome. People don't care how their QTC is, they care about how nauseous they are. They want to know if they go into Versada, and that's important to know. If you're studying, you mentioned before about, was it Jones or something that had one episode, one case, which is minimal in his 16,000 cases. So that's much more important and relevant to me. So you know, this is interesting, look, but you're recommending we do it without this fear, and I appreciate that. That's very helpful.
I'm not aware, definitely none in these studies where there were any torsade that were linked to or ondansetron use. Usually where they found the problems is when you're giving for oncology doses, like it's the 8 or higher milligrams, and there's a daily amount, like a 32 milligram threshold that you might reach. We're generally not getting anywhere close to that in the ED. We're giving a 1 or 2 time dose of 4 milligrams, and that's fine.
Should I be giving 4? Because I sometimes give 8. Is there effectiveness data?
That's funny you say that. So Will's question was 8 versus 4 milligrams. My last hospital, we actually used 8 pretty routinely. When I came to Mass General, 4 was kind of the standard. So I think anywhere in that range is acceptable. Yep. Okay. Let's round out this last part of the talk. Okay, so metoclopramide, prochlorperazine, and ondansetron. Okay, so last thing I want to talk about is something that's pretty interesting to me. I think it'll be for you as well. So obviously we use benzodiazepines a lot in our EDs. We have lorazepam, diazepam, and midazolam available for the most part for IV therapy. Obviously, we know that they on their own do have a small risk of respiratory depression. And when you mix those with opioids, the risk is higher. That's not groundbreaking. So just be careful. So the warning that's there is just to monitor them, which is no kidding. So thanks, FDA. What I wanted to get to, though, is there is particularly in back to our agitated patients again. So there are times when we want to give a benzodiazepine with an antipsychotic. That's okay. That may be warranted, but there's a concern that if you use a parenteral antipsychotic, particularly olanzapine, with a parenteral benzodiazepine, that you're going to cause excess sedation and potentially that might lead to intubations and things like that. So there was a group that looked at all of the reports that were submitted to the FDA about this over a year period, and there was 160 cases where this was a problem and 29 where they reported fatality. And so if you're just going off the numbers, that seems like a pretty high percentage of problems when you give these two things together. However, if you look at each of those 29 cases, 3 of them were olanzapine by itself. 1 was olanzapine plus benzos, and then the other ones were all olanzapine plus benzos plus a lot of other medications that can cause sedation. And so it's not really an olanzapine benzo problem necessarily. It's a polypharmacy problem, which I think we all recognize is important in our EDs today. There have been a number of studies, many in the ED over the years since that one was published, that have used these in combination together and found okay outcomes. So I bring this up because at my hospital, if I were to prescribe these 2 things together, I'm going to get a pop-up alert that tells me not to do it, that there's a risk of sedation, of excess sedation. And it's actually led to a number of safety events that I've had to be a part of that we've kind of investigated and kind of made changes based on it. So like in the hospital setting at the bedside, like it ends up turning into this situation of lots of headaches later on. So if you look at what the main organizations recommend, the European Medicines Agency says separate them by 60 minutes. Fine, that makes sense. The FDA does not actually give a recommendation. And then on the bottom here is, this is what my warning says at my hospital. So obviously the sedation, respiratory depression, death can kind of catch your eye a little bit, I suppose.
Someone's asking online about PO, olanzapine.
Yep. This is only a risk with the parenteral versions. The PO, they have not linked it to increased risk. So good question. So we use this again everywhere, particularly we have a separate section in our ED for, we call it APS or acute psychiatric services. So this type of combination of drugs might be used there pretty prominently. And that's where it can be a problem. So I put a caution on this one, not because I actually think it's a problem, but just because depending on where you practice, and some of you may actually move to the US and practice there as well, I want you to be aware of this, that there could be an increased risk. The data doesn't really support it, I don't think, but the agencies would have you believe that it does. And obviously, like if you're sedating a really agitated patient and you're using multiple medications, you know that those scenarios can go bad in a number of different ways. So just be prepared, have increased monitoring available. If you might need airway support, like you're going to be in the ED, but just be thinking ahead of, the next couple of steps of what could happen. And as long as you're prepared and kind of communicating that with your team, I think that you'll be in an okay space. So in summary, I avoid fluoroquinolones except for the couple of scenarios we talked about earlier, prostatitis and maybe some UTIs. I avoid tramadol except in the situation that you brought up. Thank you for doing that, which is that if it's worked in someone before, then that might be someone to try it in. We use droperidol frequently now, and then just be aware of the olanzapine and benzo interaction. Okay, let's take a quick break, or however long we normally take. We're going to take a 10-minute break for those online.
Est-ce qu'il m'entend maintenant?
You want to know if they're working now? You did something different.
Yes.
Sound on.
Sound on. Okay.
Okay.
But the thing is, okay, the microphone is now there. So, but you need.
That's fine. He doesn't need that. He doesn't need that.
Okay, you don't.
Oh, unless they're hearing it from that. Did you turn? Maybe that's the one that's working.
I don't think so. No. No. I bypassed the interface. So, is it okay?
I'm asking. Okay.
So,
Thank you.
it's gonna be working if the.
Okay. Thanks a lot. To get back to the presentation, I guess. All right. Okay, I'll let him do the rest from here. Okay. Thank you. I'm just waiting for Dr. Hayes to come back. He'll be back in a moment. I let you do the full screen thing though, because it's in case you know what to do, right?
Yep. All right. All right, so the last two talks are going to focus on a little bit more acute care. So we'll talk about some resuscitation related topics, and then we'll talk about some toxicology topics last, which is my favorite. So imagine that you are from the Boston area and you drive to Montreal to give some talks to some very bright emergency physicians, and you're out to dinner at a nice Parisian style bistro, enjoying a nice meal with some new friends. Let's just call them Will, Jake, and Joel. And you make it through the dinner and it's just wonderful, and you just order your dessert. And then you hear some screaming from behind you. And you're like, oh, people celebrating? That's weird. And then you realize, oh, no, they're not screaming for a celebration. They're screaming because someone in their party is having some sort of perceived medical emergency. And Will and Joel are closest. Jake and I are kind of observing this, and we see a middle-aged man that looks to be quite white and pale, not really responding, and the family screaming. This is actually a real story. Happened last night. And so
From Boston.
they were from Boston, no relation. And so Will and Joel attend to the patient, I guess. And then Jake and I are kind of right there. And anyway, quite an interesting start to my trip to the emergency program here with Will at dinner. So then I hear that it happens on flights, and I don't know. So apparently hanging out with Will, you get some exciting emergency stuff outside the emergency department. So, geez. The reason I bring that all up is because I thought for a few seconds that between my meal and my dessert, I was going to be doing chest compressions on someone that was potentially in VTAC or VFib. Turns out probably was not the case. The guy did not lose his pulses, thank God, and made it out to the.
Well, he actually lost his pulse, but he came back. So there was no pulse when I got there.
Oh, I didn't hear that
There
detail.
was no pulse.
Never mind. Apparently he did lose his pulse.
Could have been a bad bagel event, but it was awesome.
Anyway, so quite an interesting dinner, to say the least. And it made me think of my talk this morning because I wanted to start by talking about some resuscitation-related topics, and one of them is VTAC. And so in the American guidelines for ACLS get updated every 5 years. The last one was in 2020. Before that, they started to do these kind of like intermediary updates, because honestly, even in the 5 years, there's not a whole lot of major updates in resuscitation. So they started putting out these mini ones, and one they put out in 2018 was helpful. And for the longest time, for VTAC or VFib, we used amiodarone as our primary agent. And before that, like way before, we used to use lidocaine, but that kind of went away for a while. But what they said in 2018, and they reaffirmed it in 2020, was that there's some newer data, and the level of evidence now supports that either one of these can be an option for you if you have one of these types of patients. So I know in my emergency department, we've actually switched over to using lidocaine, even more so than amiodarone. They work about the same, but there's a lot of kind of like longer term issues with amiodarone, and lidocaine is just kind of cleaner. So we've actually changed our practice and traditionally now use lidocaine because of this new evidence, which is great. So you also can do that. Now, there are times when you're taking care of patients that have persistent VTAC or VFib, and despite shocks and whatever other care you're doing, it's just not going away. And there is something else you can actually do. I know you can do some fancy defibrillations and stuff too, which you can certainly try, that double shocks and all that stuff. But from a medication standpoint, one of the things that you can try is a beta blocker. And I know intuitively that may not make a lot of sense, but sometimes when they get stuck in these recurrent pathways, there's a lot of endogenous adrenaline, basically, and that's causing some deleterious effects on the patient. And so one of the things you can do is if you can block the beta receptors, that can sometimes stop that cycle from continuing. And so there were a couple of studies in the ED that looked at using esmolol to break these persistent VF or VTAC cases. And they used patients that we would normally probably be thinking about, like, what's my next thing? So they've got more than 3 defibs, they got epi ×3, and they got a dose of amiodarone. And what they did is these patients, they loaded them with esmolol and then put them on an infusion. And theoretically, you could probably do this with other beta blockers as well. Esmolol is just nice because it's kind of a quick on and off. But we kind of we want the alpha effects of epinephrine in these situations. We want the vasoconstriction and the increased and that stuff, but we don't want necessarily the beta effects. And so by selectively blocking the beta receptors, this actually can kind of break patients out of this cycle, which is really nice. And what they found, and these are the kind of a breakdown visually of the 2 studies, is the patients that are blue got esmolol, the patients who were white did not. And they actually found that there were small studies, again, so there wasn't a whole lot of great statistical significance or anything like that. But they did find that there seemed to be more patients that were able to have sustained return of spontaneous circulation if they got esmolol versus those who did not. So what I wanted to present to you today is that if you're in these situations where defibs aren't working, epi's not working, your amio or your lidocaine is not working, you've tried the different defibrillation types, think of esmolol or maybe another beta blocker, and this could help kind of get you out of that cycle and maybe get ROSC for your patient. And some of them had more of them had good neurologic outcomes at 30 days as well. Some of the other kind of summaries of the ACLS guideline update from 2020 is epinephrine. Now, I know that some of you have probably done some deep dives on where did the epinephrine use come from, and are we using the right dose, and what's the actual data to support using epinephrine in these cardiac arrest patients. Will was telling me about a case yesterday too, where I'm sure they used epinephrine. But over the years, what we found is that epinephrine, it changes the place of death. It doesn't necessarily change the overall outcome in terms of neurologic survival. And they've, even in the EMS, like the pre-hospital setting, they're even now doing really cool studies to try and figure this all out. But they've tried high doses, they've tried low doses, epi, no epi, and how interval in between the doses. They've kind of looked at all of these things. And over time, if you've looked at kind of the last 25 years or so of the guideline updates, you'll see that the language they use to support their recommendation is kind of decreased, which I think is good because I think it's consistent with what the literature is telling us. So it's recommended that it be used in cardiac arrest. This is their new language. But then for 2, 3, and 4, they've actually changed, they've kind of like downgraded their strength of recommendation, which I agree with. So they say it's reasonable to administer every 3 to 5 minutes. It's reasonable to administer in non-shockable rhythms, and it may be reasonable to administer after an initial defibrillation fail. So basically what they're saying here is you are not, I'm not saying don't use epinephrine, that's not what I'm saying. But what I am saying is that we don't have to prioritize epinephrine from the things that we know work. So if you can be doing that in combination with the other things you're doing, the chest compressions, the defibrillations, whatever else you need, it could be blood, kind of addressing your H's and T's, do those things. Medications, for the most part, are secondary in these ACLS type cases. For us, for epinephrine, I can tell you that like most patients, not having enough epinephrine is not their problem. And so for those patients, when you can kind of identify them, spread it out to every 5 minutes. You don't have to be getting in the way to kind of jump in and dose your epi. Like focus on the things that you think actually can help the patient. If it's hyperkalemia, treat that. Epinephrine is not necessarily going to, well, I guess it could technically shift a little bit, but probably a bad example, but you know what I mean. This is interesting, and I'm actually interested to hear your take on this from Canada. So in the US, we used to label our epinephrine in a way that was really confusing and caused a lot of drug errors. And we used to have it with this 1 to 1,000 concentration on it. Do you have that in Canada? What is it? You still do? Okay. So this may be of interest to you then. So back in 2016, we have this organization called the Institute for Safe Medication Practices, and they basically recommended to get rid of that on the vials. So any vial made after 2016 actually was changed, and this is how it now looks. So on the left is what it used to look like. This may be what you actually see now in Canada. And then on the right is what it looks like now. So they basically got rid of that 1 to 10,000 dilution concentration and just changed it to milligrams per ml, which is a much cleaner way of looking at it and has led to significantly less errors in epinephrine. And we don't necessarily make a lot of epinephrine errors in resuscitations, but we do make a lot in anaphylaxis cases using the wrong dose or the wrong route, and this is very helpful to get rid of this. What about some of the other things that we do in cardiac arrest? So I know that sometimes it seems like we should be doing all of the things, and so we give them calcium and we give them bicarb and we give them magnesium or whatever, kind of not necessarily targeting anything in general, just kind of treating the cardiac arrest. But the guidelines actually recommend that these not be routine. So if you have a reason to do it, then do it. So if you have a case where you know it's a dialysis patient and you're concerned about hyperkalemia, because even on the PEA rhythm, you see that it's a wide complex, like, yes, give that patient bicarb and give that patient calcium, and maybe once you get the K, you can fix it even further. But don't just give these just to give them because you want to do something, is basically what the guidelines are saying. All right, I want to give you 2 cases that present the same way, but have very different origins for it. So let's just say that you have a dialysis patient that comes into your unit with altered mental status. Their pressure is a little bit low, heart rate's a little bit low, and you get an electrocardiogram, and this is what you see on the monitor. What's your thought? Major hyperkalemia? Yeah, so I'm a pharmacist by training. I do know how to read EKGs a little bit. Fortunately, this one tells me that it's abnormal at the top. So what are you going to do? If you see this in the patient I described, what's kind of like your algorithm for treatment? What do you want to give? Insulin? Calcium, albuterol? Yep, good, all good things. If you give insulin, what dose are you going to give of insulin? 10 units? Okay. Okay, so somewhere between 5 and 10 units of insulin. Okay, awesome. So traditionally we gave 10 for a long time. We've actually updated that a little bit now, and we actually give 5 as our standard, but 10 is kind of like, if you ask most people, 10 is kind of the dose that they come up with. When you give a dose of 10 units of insulin, you can expect their potassium, I forgot to update the units. It should be 2, it's millimoles, right? Yeah, so it's the same. So 10 units of insulin should drop your K by about 1. And remember, this is temporary, this is just a shift, but that can get you from 7.9 to 6.9 or something like that, which is good. The problem is that you're giving insulin, And so hypoglycemia is a big concern with these patients, and it's one that we don't often think about enough. Some studies have found up to 10 to 20% of patients will develop hypoglycemia from the insulin they get for treating hyper K. This was such a big deal that there was this ISMP group I told you about earlier. They actually put out a whole article, a whole series of articles on all the errors we make with using insulin for treating hyper K. In fact, in the US, insulin is on one of our your high alert medications. We have like heparin, insulin, narcotics, kind of like the things that were most likely to cause problems. Insulin is on that list. So why does this happen? Well, when you give IV regular insulin, the onset is pretty quick. Usually works in about 5 to 10 minutes. It peaks in about 25 to 30, but its duration is a long time. Could be 2-3 hours. And traditionally we give our insulin with glucose, but the glucose only lasts about 30 to 60 minutes. And that's where the big problem comes in. So when you look at all of the studies and just my own anecdotal experience, the time that patients get hypoglycemic is sometime about 45 minutes in, when the glucose is wearing off, but the insulin is still sticking around for a while. The problem though for you is that you're not in that room anymore. You're 3 patients down, and you're not really thinking about that patient anymore because you've kind of like fixed them temporarily while you're waiting for nephrology or whatever the next step is. So we don't often think about these patients again. And then all of a sudden the nurse is coming to you and they're like, our patient's like really diaphoretic and a little bit altered. And you're like, what's going on? And you're like, oh, their glucose is very low. Remember, I'm not using units because I don't know what they are here. So what are the risk factors for this? Well, none of these are going to surprise you. So if you are not a diabetic patient to begin with, then you're likely not hyperglycemic. And so when you present to the emergency department, your glucose will be normal. And so when you give them insulin, it's likely to drop. If you have a lower starting glucose, if you have renal disease, which was mentioned earlier, because insulin is partially eliminated by the kidneys, and increasing insulin doses. So all of these things have been shown to be risk factors for causing hypoglycemia. So I'm going to break this down to make it very simple. And I actually did list the right units on here for you this time. So there's a couple ways you can go about this. I was talking to one of your attendings earlier. Sounds like you have electronic medical record, but it's not in the ideal state for use. It's probably one way to describe it. So you may not have this available to you, but what we did is we actually built a hyperkalemia order set. So if I have a patient who I need to treat, I go in, I order the different medications I want, but then in addition to that, and most importantly, is that it automatically checks for me glucose up front, and then a PRN glucose check, or a glucose check, and then a PRN glucose available to the nurse for later. So that way, that 45 minutes or an hour later, when you're on to your other patient, the nurse is going to get notified to check a glucose and have the ability to give glucose if needed at that point. So we have that all built into our system now because we had so many issues with this problem. The other way that you can do it is depending on what their starting glucose level is, you can give them varying amounts of glucose up front, and then you can give them repeat doses if you need it, knowing that 60 minutes is that point when you're most at risk. Now at the bottom here, I've highlighted what he mentioned earlier, which is that what we started doing more recently is the data is confusing on this if you've done a deep dive on it at all. And earlier studies used to say that the higher the insulin dose you gave, the lower you would, the more you would lower the K, which makes sense. Newer studies don't necessarily suggest that. They say that 5 and 10 kind of lower the K about equally with less hypoglycemia. So a lot of hospitals have now moved to 5 units as their standard, thinking that it will lower the K just about as much as 10 and not worrying about the hypoglycemia as much. So it sounds like you're already doing that here, which is great, but at least consider using 5 units the first time around if you need to. And then remember, if you're combining this with your albuterol or even your bicarb and your otherwise acidemic patient, those will also help shift the K temporarily for you. Ultimately, obviously, what most of these patients need is to remove the potassium from the body in some way, maybe dialysis, but this will at least help for a little while. Questions or comments on hyperkalemia? All right, same presentation, very different patient. So altered mental status, low blood pressure, low heart rate. This is a patient coming to you from a long-term care facility and they don't know what's going on. So you start to evaluate her and you notice that her pupils are a pinpoint. You're thinking, and then you look at her med list and you find opioids on there. And so you're kind of very different than the hyperkalemia. The EKG in this one is normal. You're thinking, okay, I want to reverse this. And so I'm going to give, obviously, the antidote, which is naloxone. But I want to kind of walk you through the nuances of naloxone dosing. Where I trained for fellowship and then where I worked for a bunch of years was in downtown Baltimore, which well, it sounds like from dinner that you've heard about Baltimore, either through the wire or other reasons. It's actually a great city. I do highly recommend it. The food is fantastic. But 10 years was enough, and then we moved back to Massachusetts. But anyway, a lot of heroin, a lot of opioids in the downtown Baltimore. Honestly, in Boston, we see that quite a bit as well. So we've gotten pretty nuanced with our naloxone dosing. I don't know what they do here for you in the pre-hospital setting, but I know that where we are, they give either intranasal naloxone or they give a pretty large dose of intramuscular naloxone. And so oftentimes they might come to you and they're already in withdrawal because they got too much naloxone. So that happens too. So there's a couple ways you can do this. You can give a whopping dose of naloxone and just reverse them, which obviously, if your patient is peri-arrest, do that. Like give them whatever opioid or naloxone dose you need, 0.4 or higher, and that's fine. However, there's a lot of patients that don't need that much. And if you give them too much, you're just going to cause them to be in withdrawal, which leads to vomiting and potential aspiration, and might lead to them hurting you or your staff or themselves if they're agitated and altered. So we like to try and dose it in a way where it makes them breathing and supporting their airway, but not to the state where they are aggressive. So what we do is we take a 0.4 milligram vial of naloxone, and we take a syringe, and you draw out your 1 ml of naloxone, and then you draw out your 9 mLs of normal saline or whatever you want to use to mix it with, shake it up a little bit and label it. And what you've done now is you've created a dilution. So now instead of 0.4 milligrams in every ml, you have 0.04. And what we do then is we give 1 or 2 mLs at a time, wait 30 seconds. And usually what you find is that you don't even get to the full syringe and they're awake, or at least awake enough for you to, to be comfortable with where they're at. O2 sat wise, end-tidal CO2 monitoring, whatever. So that's what we do. Now, again, this is not for the peri-arrest patient. And I already know what question I'm going to ask, so I'll answer it up front. And that is, what do we do in the era of fentanyl and all the synthetic fentanyls? Like, does that change our naloxone dosing? We used to think so. When this first started, we thought we needed to give patients lots, like 10 milligrams of naloxone. It turns out that is not the case. For almost all the opioids out there, naloxone binds so tightly to that mu receptor, it bounces off anything else that is on there, including all of the fentanyls. So you should not need to change your dosing much, if at all, even in the era that we're in right now, where there's a lot of synthetic opioids out there. Okay. Questions on naloxone? Comments? Okay.
Yeah.
Yep.
Does the initial amount that you've given in your diluted solution give you an idea of how much to put them on an IV drip?
Yes, I'm so glad you mentioned that. Okay. So, oh yeah, for those online, the question was, when I use that dilution and we actually get a more exact wake up dose, so to speak, does that help drive our dosing for the infusion? And the answer is yes, it does. So if you look in Goldfrank's or at any of the tox textbooks, you'll see that you take 2/3 of the wake up dose and start that as an hourly infusion if you need to. So let me back up a bit. When do I use an infusion? If I'm giving more than 1 dose of naloxone, I'm going to think about starting an infusion. So if I'm going for that second dose 45 minutes later, I don't want my nurse to be having to do that every 45 minutes. So that's when I'll start thinking about adding my infusion. How do we do it? If we are able to find the actual wake up dose using this approach, that is really helpful, because then you know approximately what you can start them at. Alternatively, if you give them a whopping dose and it wakes them up, like, you don't know what the actual dose was that was needed. So you're going to probably overestimate the infusion dose, and then they're going to be in persistent withdrawal until you figure out what that right dose is. So this approach is very helpful if you end up needing to start an infusion. Thanks for asking that. Okay. So one of the questions we also get asked is, all right, so I have a cardiac arrest patient in front of me. I'm thinking it could be an MI or a PE or something that would benefit potentially from thrombolysis. What dose do I use? So what's your thrombolytic of choice here? TPA, perfect. Okay. So, tenecteplase? Okay, good. So that's good. So we still use TPA at my hospital for this indication we're going to talk about today. However, for strokes, about a year and a half ago, we actually moved from TPA to TNK. So we're actually using TNK for all of our stroke cases now. So the same principle applies. So we'll go through it, even though you may have switched over a little bit. Our group didn't feel comfortable yet with all the data in cardiac arrest to switch over, so we're still using TPA. So the first thing is that whenever we hear TPA or TNK or any of the thrombolytics, we kind of like immediately get a little bit scared and we're like, oh my gosh, this is a drug, we're going to mess it up, the dose is going to be wrong, they're going to bleed. So I like, again, you know me already, I like to keep things simple. So if you open the box, I'm going to kind of walk you through a pharmacist life for a second. If you open the box for TPA, what you have inside are 2 vials. The one on the left is water, which is 100 cc's, and the one on the right is the drug itself. It's just a powder, and it's 100 milligrams. Basically, they give you this like adapter, which is really helpful, obviously, for transferring the fluid over. So I'm going to open my water vial, and I'm going to put the adapter in, and I'm going to basically flip it upside down, and I'm going to let the water drain in. It usually takes about 2 minutes for the water to drain in by gravity to the bottom. The good news is that by the time it's all in there, it's usually dissolved. And so from like, I'm thinking about a cardiac arrest or a stroke case, I can usually have, from the time we make the decision to give it to the time we actually are ready to administer, maybe 3 or 4 minutes. So we're not talking about I know in that scenario, it seems like a lot of time, but it's not overall a whole lot of time. It's dissolved by the time, and because it's 100 milligrams in 100 mLs, it's 1-to-1, 1 milligram per ml or cc. So that's really easy math. So if I want to give 50, it's very easy to draw up 50. That's it. So the mixing of it is actually not that complicated. If you look at all of the data, some of these are with alteplase, some of them are with TNK. What you'll also see is the condition. And I'll just tell you, summarizing this in the next 2 slides, is that the majority of the data where it works or where it may be beneficial is PE. Obviously MI as well, but PE is the main one. So you can see PE, AMI, and then kind of like undifferentiated cardiac arrest. And they use a varying amount of doses. Some use 100 milligrams, some use 50. So it's kind of like all over the map in terms of what they do. And then for the MI dosing, it's really weird. Sometimes they'll use like 15 milligrams up front and all this other stuff. You don't have to worry about any of that. What do I recommend? If I'm using TPA, and you can do a similar thing for the TNK, I am going to give 50 milligrams. So I'm going to prepare the way we just went through. I'm going to give 50 milligrams IV push, and then that gives me the room to repeat it again if I need to. Obviously, like CPR, it had been thought that if you give a thrombolytic and you're doing chest compressions, that there would be a higher risk of bleeding. Like, yeah, of course there is, but they're dead. So I need to fix that first, and then we can worry about the broken ribs or the bleeding. So CPR is not a contraindication, and the recommendation is that if you give a thrombolytic, you should probably continue high quality chest compressions for at least 15 minutes to make sure that you give that patient a chance to have that circulate and act wherever it needs to, whether it's a PE or in the cardiac vessels. The evidence is best for PE. We should not be using this in undifferentiated cases. So if you have no suspected PE or MI, like don't really consider TPA or TNK. In terms of other anticoagulants, in general, like you might be using heparin or something if you also have an MI, but you can use TPA with those. It's not a contraindication, and then consider TNK, which we're doing now too. So 50 milligrams, which you can repeat, continue CPR for at least 15 minutes are the main ones, and then PE is probably the primary that you should be thinking about. Yes. So the question was, what about the second and the third drip? So the second and the third drips usually come into play when you're treating an MI that you are not sending them to the cath lab for. When they're in cardiac arrest, I'm not worrying about any of the infusions. We're just doing the high dose bolus stuff to try and get as much circulating as we can to try and break up that clot and restore circulation. Okay. All right. We got hit pretty hard back in March of 2020, probably till about June with COVID. I'm not going to talk about COVID really today. I just want to use this as an intro for this section. And we learned, we've been doing intubations and things forever, but we learned a lot about how we were doing it and we could be better. And that's kind of what I want to present to you today. We had shifts when we would intubate 9 or 10 patients per shift in that the very first strain that came along. It was really, really bad. And our city got hit pretty hard. But the newer strains, we're not intubating hardly anyone for COVID anymore. I don't know if you are, but it's very different now than it was, which is good. But we learned a couple of things. So we put together a couple of medication management guides to do this, and none of this is going to be surprising to you. And I'm not actually going to go through this in a lot of detail. I can share this with you later. But we kind of walk through like each of the steps that we normally would do had a little bit of the tweaks to them. What I want to highlight is the key points. And that was that we needed to, early on, we needed to deeply sedate them. These patients, for whatever reason, would just chew through their sedatives. Many of them, even if they weren't hypotensive, and we weren't normally going to predict that they would get hypotensive afterwards, they did. And so we actually started prophylactic norepinephrine prior to the intubations in those patients early on. And then a lot of them needed to be paralyzed also to be synchronous with the vent, and we needed to make sure that the sedation was adequate there as well. So we're just going to skip this. We can share that. Here's one of the things that we learned. When we're giving patients sedation afterwards, which we always do, I'm not sure what your practice is here. We will typically use something like a propofol or a dexmedetomidine as our sedative afterward, and then we often combine that with an opioid infusion. Doesn't matter. It could be fentanyl, it could be hydromorphone, whatever. But what we fail to do, and what I want to implore you to do as you go forward, is that whenever we're putting them on those afterwards, and we need to change a dose. So they're on a hydromorphone infusion, they're not getting enough sedation or pain management. I need to up that dose. What we learned in COVID that we should have been doing, but we weren't, was whenever you change the rate, you also have to give them a bolus. And I'm going to explain that to you in a way that hopefully will be easy to understand. So let's just say that I started fentanyl 50 micrograms per hour. That's kind of what they're getting. And I want to increase it to 100. Well, if I go to the pump and I change the dose on the pump from 50 to 100, that's fine, it'll do it. But it takes a full hour now before they get that extra 50 micrograms that you wanted them to get. So whenever we're making those changes, you got to remember that it's going to take that time before they get that full extra dose that you want. So if you want them to get it now, which you do, because they're not sedated enough, then you need to give them a bolus every time you're increasing that infusion. And that applies to all of our opioids. Propofol, not as much because it works so quickly, but most of the other medications that you're using, you do have to bolus every time you change that rate. So just remember that.
The bolus amount is the difference between the two rates?
Yeah, so Will asked what the actual bolus amount is. That can vary. Usually it is either the same or half of the dose you're planning to go to. Okay, so just some take homes. We did early vasopressors. We added additional induction agents. Honestly, it was really strange. We actually were using ketamine or etomidate, and then we're adding midazolam on top of that just because they were so difficult to control after the intubation. And then just remember the key take home point here is the bolusing for any intubation infusions afterwards. So I want to talk quickly now back to the intubation stuff. And there's this ongoing, I'm not even going to call it a debate. I'm just going to call it a discussion about etomidate and ketamine. I'll tell you up front that I've used them both a ton and I like them both. They both have their purpose. But there's some newer data coming out. There's a couple of registries that are kind of cohorting tons and tons of intubation patients and kind of reporting out their outcomes now that are helping us a little bit. The one that caught my eye initially was part of the NEARS, the National Emergency Airway Registry Study. So this is taking patients from all across the US. And one thing that they reported is I think a lot of us, when we're choosing ketamine, we're thinking that one of the reasons we're choosing it is because we think it's going to affect the blood pressure less. In fact, maybe it'll even increase the blood pressure in a patient who's kind of borderline. But what this study reported is that there was actually a higher risk of hypotension with ketamine versus etomidate. And that was like kind of eye-opening. It's like, oh, that's kind of counterintuitive or counter to what we thought. However, there were some flaws to this, and I'm going to show you that in a second. But interestingly, there was a meta-analysis that looked at all of the studies to date right around the end of last year, and they actually confirmed the finding that they found in this. So ketamine may not be as neutral as we thought it was, I guess. Now, what you should know about the data that I just showed you with the 18 versus 12% is that the ketamine group actually was more likely to develop hypotension anyway, just because of who was in that group, because it wasn't totally randomized. So there are more trauma, more sepsis, more difficult airways, and more VL. So just know that at baseline, the ketamine group was a little bit more challenging. And that's kind of probably why they were choosing ketamine in the first place. So where does this leave us? So ketamine can increase your catecholamines. So you actually, in an otherwise healthy patient that you're intubating, maybe for asthma or something, you will notice you give ketamine, and after their intubation, generally their blood pressure is going to be higher than it was prior. And you will see that. So most patients do respond that way. But there is this concept of catecholamine depletion. So if I have a patient that's been in a shock state or some stressed state for an extended period, they might have kind of spit out from the adrenal gland, all the catecholamines they can. And so when you give ketamine, it's actually not going to cause any further release of catecholamines. And there was a couple of patients who did poorly around that time that they reported. Another group reported that if the shock index prior to intubation is over 0.9, that's a good predictor of hypotension. And so we use that actually in our emergency department when we're kind of doing our evaluation. And then I know there's been debates over the years of etomidate use in septic patients. I'm not going to talk about that today, but what I am going to tell you is that another group actually found etomidate reduced the risk of hypotension when using it for intubation in sepsis patients. So I know long term, but at least in the ED, like it actually was better than ketamine, at least in that one study. So again, I'm not telling you not to use ketamine. I love ketamine. I think you should be using it a lot. But I guess what I would say is that always be prepared for hypotension in any intubation patient. And that whether you choose etomidate or ketamine, it doesn't necessarily change your risk. You still could have a hypotensive patient you're dealing with afterwards. So don't reach for ketamine thinking that it's going to save you from the hypotensive effect, because it probably won't compared to etomidate. All right, so just to summarize, now we can use lidocaine along with, or kind of opposite, or amiodarone for VT or VF. Esmolol should be on your algorithm as well for the refractory cases. Definitely anticipate hypoglycemia with hyper K and be prepared for it. TPA, we give 50 milligram bolus, which you can repeat, and it's similar for TNK. And then plan for peri-intubation hypotension, regardless of which agent you choose as your primary induction. Okay. Questions, comments? All right, last one. All right, can you see my slides online? Yes, okay, awesome. Okay, so we're going to wrap up with some toxicology, which is kind of my bread and butter. Hopefully, we're going to focus on antidotes, which you can probably tell from the title here. I also like Taylor Swift, but I did not get tickets to any of her concerts, including the ones in Boston, unfortunately. I was not fortunate enough. So let me know how it goes if anyone gets to go. All right, so back when I was a first-year pharmacy resident, I had this case. I was doing my ED rotation, and I was with this prominent toxicologist, Ed Boyer, and we had this case come in. And it was a 20-year-old who was found down in the woods, completely unresponsive, and tachycardic, as you see here. And he was brilliant, and he's part of the reason I actually went into toxicology in the first place. But we were in the ED, and he was like, "I think she's anticholinergic. We should give her physostigmine." And I was like, "Oh, that sounds cool. We should do that." So we did. We gave her physostigmine, and within 2 to 3 minutes, she sat up, told us her name, told us where she was, told us that she had taken a bunch of olanzapine, which is very anticholinergic, and was mostly back to baseline. And I was like, other than naloxone, I can't think of too many other things where I actually get to watch pharmacology in action that quickly. And it was just amazing to me as a young pharmacist. So that was that. Now this guy, I will tell you, I'm not as dedicated to as this is Dr. Christensen, who's a Scottish toxicologist, and he, again, I'm not as dedicated as this guy. He used to take poison, to the threshold to see like how it might affect him, so that way he could give himself reversal agents. So yeah, I don't do that. But anyway, he helped discover the utility of physostigmine in treating anticholinergic poisoning. Now, for those of you that have practiced long enough, you probably remember the coma cocktail of drugs that we would give for unresponsive patients that came to the ED. And that included things like dextrose, thiamine, naloxone, flumazenil, and physostigmine. Now, that was sort of prominent in the US for a while, until 1980, when there were 2 cases where physostigmine was given, and within a short period, patients developed asystole. And then the use of physostigmine plummeted for generations. Based on 2 cases, by the way, case reports. I think there was one other one that was around there too. But if you think about it, there are so many anticholinergic agents out there. There's like the traditional ones, the prototypical ones like atropine, glycopyrrolate. But then there's other ones that we use for like bladder control, like oxybutynin. And then there's the inhaled ones like tiotropium and the scopolamine patches. And that's just like the true anticholinergics. Then there's all the categories of drugs that we use that just happen to have anticholinergic properties along with their primary ones, like antihistamines or antipsychotics. And then there's even plants. So lots and lots of anticholinergic things out there, which means you're likely to see a case or 2 here or there in your emerge. Traditionally, we've used benzodiazepines as our primary treatment because these patients typically present with agitation, altered mental status. And so benzos seem like a good choice. And they are. I'm not going to argue against them. They are. But there was a group in Boston many years ago now who published on a handful of patients that compared benzos versus physostigmine. And what they found was pretty shocking. And that's that for agitation, physo works almost 100% of the time, and benzos not so much. Delirium, physo great, benzos not so great. And the complications, even though we're so fearful of physo, were actually lower with that versus benzodiazepines. Then there was kind of a lull in the literature for almost 2 decades. And then a bunch of tox folks from poison centers and EDs started to like publish more. So this group published on 191 cases back in 2018. And there was a whole host of different products that were involved in these overdoses. And what was interesting is about 75% of patients were treated just with physo, no benzos. 20% were discharged directly from the emergency department, which is great. 57 in ICU, and then most patients had no documented adverse effects even after the physostigmine. Now, again, remember, I did say earlier that poison center data, not the best at capturing safety signals just because of the way the reporting works, but with that caveat, they reported very few. Another group from the poison center reported on a smaller cohort, and here's the interesting thing is that the poison center recommended physo in 81% of cases, and yet only 37% of the time it was given. And that's because we on the other end of the phone are like, I don't know. I've heard some bad things about physo. I'm not sure I want to do that. And so, but when they did do it, it actually controlled delirium much better than all of the other therapies that were out there. So when do I think about physostigmine? I think about it really honestly whenever I have an anticholinergic case that has either peripheral, pretty severe peripheral, or definitely central antimuscarinic effects. So you think the mad as a hatter, the hot as a hare, all those things. But then keeping in mind that there were those associated adverse effects, and those were with TCAs, the 2 asystole cases I showed you about earlier, we're going to get an electrocardiogram first. We're going to look at it, and we're going to determine, like, is it just sinus tachycardia that we know happens with this poisoning, or are there other things going on as well? What dose do I give? We usually give 1 or 2 milligrams, and you can repeat it in 15 minutes, and it lasts about 60 minutes. And that's helpful because some patients do need to get redosed, kind of like I think of it like a naloxone basically for anticholinergic poisoning. Now, just in case you're wrong, if it's a different diagnosis and now you're giving them a whole bunch of extra acetylcholine, you could have a cholinergic patient on your hands now. This rarely happens, but just be prepared, have atropine around at the bedside just in case you overshoot. That's fine. So here's kind of my algorithm. I have an anticholinergic case, I get an electrocardiogram. If it's abnormal, it doesn't mean I'm not going to give physo, because there are studies now that used it in patients with TCA poisoning and they all do fine. I think we just need to keep in mind that TCA poisoning is very complicated. Anticholinergic is just one piece of that. There's a lot of other receptors involved, and so it's not clear cut. But But anyway, I'm going to give lorazepam or diazepam or whatever you have. If it's a normal EKG, then I'm going to give lorazepam because they're going to need it anyway. And then I'm going to give my physostigmine. Now, normally, this is the part of the talk where I would tell you, if you don't have this in your ED, get it in your ED. But I can't tell you that today. I just spent 5 minutes talking about physostigmine. And about a month and a half ago, the company that made physostigmine went out of business. So you and me and everyone else can no longer get physostigmine right now. Hopefully, someone else will pick it up and manufacture it. So I said all of that to say that we need an alternative, which is what I'm going to talk about next. Not a great one. So in our hospital, you probably have this. We have ribostigmine patches. Now, you're thinking about an acutely agitated, delirious patient from anticholinergic poisoning. You're like, hold on, sir. Let me get you that patch. We'll put it on, and now we're going to watch you for the next 72 hours and see how you do. I'm not telling you this is the perfect replacement, but it's definitely gaining traction in the toxicology world. A lot of posters were presented at our last year's tox meeting. Actually, this coming year is in Montreal. I just thought about that. Yay, I'll be back. So they're using patches, and they're also using, there's oral tablets. So you might have to do some, NG tube or whatever to kind of get that in place if they can't take it. But again, none of these are great alternatives, but this is what we have available to us for cholinesterase inhibitors now, with physostigmine being unavailable. So instead of getting Pfizer, which you can't get, try to find some of this around just in case you need it. The tablets obviously act faster than the patches. And there's only like 10 cases reported in the literature on all of this right now, outside of the abstracts presented at our tox meetings. But I expect there to be a lot more this year because this is a lot of poison centers are recommending this now. So you might call and they might tell you to do this. We actually, at my shop, we kept our physostigmine even though it's expired. And so I have a stock near my office that has like 100 vials of physostigmine. And as we get cases, we're actually having consultations with like legal and ethics and then the family and kind of talking them through like, hey, all we have left is expired drug. Here's what it could potentially offer. And we've used it a couple of times and it's worked. Obviously it works really well because it doesn't lose its potency overnight. So we still have some expired Pfizer, which is interesting. What? Go ahead. I talked to Joel all last night, so you can go first. Yep. So the question was how long past the expiration? So when the company first started having shortages of this, it was 3 or 4 years ago. And so they sent hospitals like a letter that said, I know it's expired on X day, but you can continue to use it to whatever date. So we're 3 to 4 years after it actually it legitimately expired. And we're about a year after the company's extended expiration time. We know from other stuff that as long as it's kept in a reasonable temperature, it should be fine for much longer, but we're having that discussion. Joel? Okay, awesome. All right.
Did you imply that also that lorazepam should be given always before physostigmine?
Yeah, so the question was about giving lorazepam before physostigmine. What I find is that the Pfizo works really well, but a lot of the patients still do require a little bit of just additional agitation support. And so that's why I recommended giving them together. I definitely would recommend, with what we know right now, to give benzos along with your ribostigmine because you know it's not going to kick in for a little while. So you're kind of going to be, your hand's going to be forced to give a benzo first anyway, unless the situation resolves.
That should be expired lorazepam.
Yes, only expired lorazepam, yes.
There's no other worldwide manufacturer of physostigmine?
There is not. No other manufacturer that we're aware of. It's very disappointing for tox people like me. Okay, when I was in Baltimore, so my parents, oh, sorry, go ahead, question. Yeah, so she asked a really easy question about US politics that I'll take some time to answer. Just kidding. Yeah, she asked about aren't there stopgaps in place to prevent that type of thing from happening where a company can just kind of shut down. We've suffered, I don't know how it's been here. Over the past 15 years or so, we've suffered from a lot of drug shortages over the year. And they varied. A lot of times it's been bicarb. It's been things that we would legitimately use in the emergency. Norepinephrine has been a lot of our benzodiazepines. So there have been movements made through our Congress to like try to put laws in place where companies need to alert you earlier and things. But this particular one, it was about finances. They just kind of went out of, and we don't have like control, government controls to like say, no, you can't, here's money. So no, we didn't have a way to prevent that from what I know. So when I lived in Baltimore, so I finished my fellowship in 2008, and then I worked as the first ED pharmacist there for 8 years before I moved back home to Massachusetts. But my family still lives in Rhode Island, which is the state right below Massachusetts. So it's about a 6-hour drive, and every Thanksgiving, US Thanksgiving, we would travel home, and that's in November. It's a Thursday, it's always a Thursday. And so I think it was the Tuesday before that, I was getting ready to wrap up my day shift. And right as I was getting ready to go home, we got a call from the EMS that was bringing a patient in. And it was this patient, actually. She was a 47-year-old, and her only history was hypertension, for which she took amlodipine. And they said that she had taken her whole bottle like an hour before, and with some ethanol. And the presenting pressure, they told us, was 103/57. So I was a little bit concerned about this, because if you know anything about Baltimore, like everyone was really hypertensive all the time. So this to me was concerning, especially in a patient that that was her only blood pressure med. I just had this feeling that things were not going to go well, and they didn't. So one of the first treatment options we use when we have a calcium channel blocker overdose is calcium, and this makes inherent sense. The data is not super great with it, but we still do it. What I wanted to talk about today, though, quickly, is which calcium salt to give, because we have a couple of options. We have calcium chloride and we have calcium gluconate. And in order to get the same amount of elemental calcium, you need 3 times as much of the gluconate to get it. That's all fine. One of the things that I heard early on that people used to describe to me was that there's this theory that calcium gluconate needs to be activated somehow in the liver before it's actually going to work for you. So I kind of investigated this, and I was like, that doesn't make a whole lot of sense. And so I found this study, which might be the best study of all time. And what they did is they took patients who were undergoing liver transplant, and they were in the phase of transplant where they had no liver. So they had taken out the liver. And they gave patients calcium chloride or calcium gluconate, and then measured ionized calcium levels and how long, and the duration of how long it took to get to the level, whatever. And they found that there was an equal rise in ionized calcium. And I was like, well, if you're going to prove something, I feel like this is probably a good way to do it. So I was convinced after this study, but there was a couple of other cool studies too. One looked at dogs and children, and they found the same thing. And then a third one looked at ferrets and in vitro blood, and they found the same thing. So whether you have no liver or a child or a dog or a ferret, if you give calcium chloride or calcium gluconate, your calcium level will rise at the same rate and to the same degree. So the point here is whatever calcium you have, use that one. That's the right one. What about glucagon? So in the early times, we used to use, we still use glucagon for beta blocker overdose. There's actually a good mechanism why that could work. But for calcium channel blockers, there was never really a great reason why it might work. And there was actually a group actually from Canada that started this, that published on basically an evidence-based guideline on calcium channel blocker overdose treatment. And they now recommend not to use glucagon. So I realize also, kind of like our penicillin discussion earlier, that it can be convoluted. Like you probably have patients that are on both. A lot of patients are on both a calcium channel blocker and a beta blocker. And they don't always tell you like, I only overdosed on this one. I didn't touch that one. So you may not know. And so am I saying don't give glucagon ever? No, I'm not. But if you think or know that it's a real just calcium channel blocker, just skip the glucagon altogether. It's expensive. We don't always have a lot of it. It causes patients to vomit in the doses that we need, and sometimes that's not a good thing in these cases, so just skip it. One of the things we also do is we grab vasopressors. They're hypotensive, they're bradycardic, so we're gonna grab vasopressors, which makes sense. Which vasopressor should you use? In general, in toxicology, norepinephrine is probably a good first choice for most things, because a lot of times you need vasoconstriction to get that blood pressure up, and this is no different. If you need a secondary vasopressor, you're going to be looking at the heart with your bedside ultrasound. So you're going to figure out what the squeeze is, and then you can kind of use that to dictate which one you do next. If they need more squeeze, maybe use epinephrine. If they don't need that, then maybe use vasopressin. You can kind of choose based on your exam. The reason I bring this up is that the doses that you may need are much higher than what you're used to giving for sepsis or even cardiogenic shock or whatever. So don't be afraid to push the limits on your vasopressor doses for the calcium channel blockers. One way to differentiate between beta blocker and calcium channel blocker, again, it's hard if they overdose on both, is that calcium channel blockers, especially in overdose, lose their selectivity for like the calcium channels wherever they're supposed to go. So for amlodipine, that's usually on the vessels. But in overdose, it's going to affect all the calcium channels. So it's going to affect the ones in the heart. It's also going to affect the ones on the pancreas that control insulin release. And so it is inherent in calcium channel blocker overdose that they're going to be hyperglycemic. And usually the degree of hyperglycemia is related to how sick they are. So you can use that as a sort of a surrogate marker. Okay, now on to the good stuff. So in the general resting state, like right now, most of us are using fatty acids for our energy source for the heart. But when the heart gets stressed, it switches over to carbohydrates. And we're not really good at utilizing the carbohydrates. And this is where insulin comes in. Insulin can help the heart utilize the carbohydrates better and more efficiently, which is why we're giving, part of the reason why we're giving high doses of insulin for these cases. Have any of you done this, high dose insulin yet? No? Yeah, okay, I've seen a couple nods. So high dose insulin. What I mean, like in a normal patient, we talked about earlier, 5 units of insulin for hyperkalemia. That's like, I don't know, 0.01 units per kilo, some really small number. For this, we're talking about 1 unit per kilo. So for a 70 kilo patient, we're talking about 70 units of insulin, and it could be higher. So you give them this bolus, and then you put them on an infusion of that same amount per hour. So you're talking about 70 units up front, 70 units an hour. It can go up to 10 units per kilo per hour. So you could be talking about 700-ish units of insulin per hour for 24 hours or however long they need it for this support for their heart. Not surprisingly, you have to monitor potassium levels when you're on this much insulin. And you also have to monitor glucose levels. Not surprising. Now, what I will say, though, is the number of glucose receptors in the periphery is saturable. So you actually don't need as much glucose as you think you would. You do need some, but you don't need as much as you think. And if you're on the flip side, when you're shutting the drip off, maybe in the ICU, the effect of the insulin prolongs for up to 24 hours. So you typically need glucose support for a while, even after you wean them off of the insulin infusion. This is just a suggested starting amount of glucose, but you're going to need to do what you need to do in the moment. Not surprisingly, if I were to write an order right now for 700 units of insulin, someone's probably going to call you and say, did you make a mistake? And so to me, it's important to talk about this stuff ahead of time. So that way, when you do have the case, the right people at least are aware of this as a concept, because it's not new in toxicology, but it is new in general compared to other therapies. So it's not, the nurses are going to be a little bit freaked out about this. Pharmacy might be freaked out about this too, even other physicians you work with. So just talk to people about it as you're doing it. The dose we need is so high. And then I'm not going to get too much in the weeds here, but just know that the standard insulin infusion that you use is not very concentrated. So for like DKA or something, it's not very concentrated. If I were to use that same insulin for this, I'm going to be giving them liters and liters of fluid that you don't want because you have a poisoned heart, remember. So we actually have a separate toxicology only concentration of insulin that is just for this purpose that's much higher and gives a much less fluid volume. In fact, we actually have a guideline for this, and I'm happy to share that. So if anyone here, if you have one or don't have one and you want to develop one, happy to share what we have with you. So, but these are all things you need to think about, hopefully prior to the case coming in, so that way you're ready when it gets here. All right. I think I heard last night that many or all of you will get to rotate at the Poison Center in New York for toxicology at some point during residency. That's amazing. So when I was a fellow, we used to take the train every month from Baltimore to New York City because they have every month they have a case conference. And when you walk in, I don't know if they do it the same now post-COVID, but back then there was a piece of paper on a table and it usually had 10 or 12 cases on it. And you just picked it up and you went and sat down in this big auditorium. And over the course of the next 2 hours, their fellows would present 4 of the cases or so. And all they told you was essentially this amount of information. And so you had no idea what was going on. And you just they presented. And then these tox giants like Bob Hoffman and Goldfrank would just kind of like talk about all these cases. And you're just kind of sitting there absorbing it all. It was amazing. But anyway, back in 2007, one of my first ones I ever went to was this. This is what was on the table. 17-year-old girl developed seizures, cardiovascular collapse after bupropion and lamotrigine. They try and resuscitate her for over an hour with nothing. And then an anesthesiologist at the bedside recommends this novel antidote. So I'm like, oh my gosh, this is happening during my fellowship. This is so cool. This is her initial EKG. I think her QRS at this point was measured at 140-ish milliseconds. This is about 6 hours after the overdose. About 3 or 4 hours later, this is her EKG in the ICU. I think it was up to 160 or 170 at this point. And then shortly after they snapped this picture, she went into cardiac arrest that lasted over an hour. This is the course of her resuscitation. So you can see they did a lot of the standard stuff, lots of EPIs, lots of amio, mag, calcium, bicarb, a couple of infusions. And then right around the hour mark is when you see this intralipid. This is the novel antidote given. And then from that point on, she actually retained circulation and actually walked out the door like a week later or something. This is actually published in Annals. This is the first human case of lipid being used in a non-local anesthetic toxicity case. And they presented this at Poison Center. And I was like, this is amazing. This is going to be the game changer of toxicology. Turns out it was not. But at the time, we thought it was. What am I talking about here? I'm actually talking about that white liquid that is fat, 20% fat, that is part of like parenteral nutrition and things like that. We actually stock a bag just like this in my ED in case we ever do need it for tox purposes. One of the initial doctors who kind of discovered this as it's used particularly for local anesthetics is a guy named Guy Weinberg. And he has a site called Lipid Rescue where he has a lot of information about lipid stuff on there. The way that we think this works is that it used to be a lipid sink was the initial theory. We think it's more of a lipid shuttle now. And so basically what we think it does is it encapsulates the drug and then shuttles it off to non-vital organs. So not your brain, not your heart and stuff like that. And then it gets eliminated. So that's kind of the working theory of what it actually does right now. What I wanted to kind of point out to you now is I was fortunate to be part of this international group that published the guidelines on kind of when to use it. They're like 7 years old now, but we looked at every piece of data that was out there on lipid. And what we ended up finding is that there's not a lot of it, which is not great. Where I recommend it is that if I have a patient who is either in cardiac arrest or has a brain or cardiac dysfunction from their poisoning, and we've already gone through all of the standard therapies, that's when I'm thinking about lipid. So like for TCAs, for example, or let's go back to our case from before, our calcium channel blocker. I'm doing my insulin, I'm doing my pressors, I'm doing my calcium, I'm doing all those things first. If those are not working, that's when I'm thinking about potentially intralipid. Go ahead. Yep.
Would you favor more kind of evidence that particularly the ECMO now or the trial?
I'm glad you mentioned that. So her question was ECMO. I'm actually going to talk about ECMO briefly after this, so let's hold that question for now. So lipid, cardiac arrest, or when the standard therapies have failed. That's generally what I'm thinking about. I'm not thinking about this at first line for anything except local anesthetic toxicity. That's really where I find that the data lies. I'm not going to go through the dosing because you can look it up when you need it. We generally give a bolus. I don't generally do the infusion part. This is what it looks like. It's pretty thick. You can give it over like as a push, which seems weird to inject a bunch of fat into someone, but you can let it run in by gravity as well, which is what we generally do. Not surprisingly, when you do this, you are at risk for fat side effects like pancreatitis and fat overload. But again, in the moment of a cardiac arrest, you're probably not thinking about these potential side effects, and that's fine. Just know that they can exist. The one I want to point out to you is the CVVH ECMO interference. Early on, we thought this was a thing, and it has been reported. I'm going to circle back to that in just a second. Also, not surprisingly, when you give a big fat load, labs you draw afterwards can be affected by this. So if you can, draw your labs before, and then just know that some of them are going to be messed up afterwards for an extended period of time. The other thing is stability with Resus meds. If you can, these patients are generally going to have lots of lines going in. Give the lipid in a separate line from other medications because other Resus meds can have interference with it. Let's get this too. Okay, very last case that I'm going to talk about ECMO briefly is another shortage thing. So just for the sake of a case presentation, 46-year-old, very low GCS, hypotensive, ingested a bunch of TCA, so nortriptyline, amitriptyline. This is the EKG that you see, which is obviously really scary. So one of the things that you're going to choose to do first is sodium bicarb. That's kind of like your standard therapy for seeing this related to any sodium channel blocking agent. The problem, at least in the US, is that we have been on and off of having bicarb available for many years now. Many times we don't have it available, it's on shortage. So the question is, what do I do if I have this case but no bicarb? That's the question. And the answer is, I go to this page, I confirm that it is on shortage, and it always is. What I do in place of this is I generally need sodium. That's what I really need to fix this problem. And I have other ways to get high concentrations of sodium. So we're using hypertonic saline if I don't have bicarb available. We actually use this in place of bicarb during the initial phases of COVID when we had patients overdosing on hydroxychloroquine. We actually use this instead of bicarb, and it worked. So a lot of complicated math here. I'm going to make it really easy for you. 1 amp or 1 vial or 1 syringe of bicarb is 50 milliequivalents. It's the same amount of sodium as 100 mLs of 3% sodium chloride. That's it. Very easy. So we just infuse 100 mLs of sodium chloride 3%. You can do it peripherally. It's safe, just like you would with bicarb. All right, I'm going to now answer your question. So there's 2 resources as I wrap up. I think these are my last 2 slides. There is an international group of nephrologists, toxicologists, and a lot of smart people that have basically over the last decade or so been reviewing all of the evidence for when to use dialysis or other ways to remove toxins. And they publish it on this site. They have, for us that like short, sweet in emergency medicine, not 4 hours of lectures like I've been giving you today, but for those of us that like short and sweet, they have a one-liner. So it's like, digoxin, don't use dialysis. And then they have a link to their full peer-reviewed publication as well. So whatever you want to look at, it's all there for you. This is a super awesome website. It's free to access. So anytime you're trying to figure out what you want to do for dialysis, this is a helpful one. And then the last one is ECMO. So I'm glad you brought this up. I can't think of a better reason to consider ECMO than a toxicology case. What other scenario do you have where you know that theoretically, as soon as that poison is metabolized, they should be back to normal, right? Unless there was some other injury to the heart or whatever. So ECMO makes a lot of sense in these scenarios where there's actually like a defined time at which point you might be able to get off of it. And what we found in tox patients is the survival is up to 61%, which is way higher than almost any other reason that you would be using ECMO. So it kind of confirms what we thought. And there's more and more data coming out as the years go on. So if you are at a place that can do ECMO, or you can get someone transferred to an ECMO center, then yes, I would consider that even before lipid. I absolutely would do that. That being said, if it's going to be a wait or you don't have it available, that's, lipid might come into play there for me, or even methylene blue or hydroxychloroquine, kind of like going down my like really downstream treatments. But ECMO, I think you should consider early for cardiac, and you can use a lot of times what we're using for tox is VA ECMO, bypassing the heart. But yeah, so glad you brought that up. All right, so in the end, don't fear physostigmine if you have it. Calcium chloride and calcium gluconate, use whichever one you have. For calcium channel blocker overdoses, no glucagon, but use high doses of vasopressors and insulin. Stock lipid for when you need it, and for TCA poisoning, you need sodium. So if you don't have bicarb, you can use hypertonic saline just the same. Thank you for listening to me for all this time. I really appreciate it. Okay, yep, last couple questions.
I guess related to the physostigmine, is there a same shortage issue of neostigmine?
Oh, great question. So the question was neostigmine. There's not. The neostigmine is available. The problem is that neostigmine does not cross the blood-brain barrier. And so for any of your central anticholinergic effects, it's not going to fix those. So yes, it's available, but it's not going to be great for this case.
Second one, any issue with lipid rescue and fat emboli, is that ever a concern?
Yep. So fat emboli is one of the concerns with giving lipid. There is a maximum amount that we try and give to minimize that risk, but it is a risk and it has been reported.
Hi, Wayne Choi here from Virtual. I had a question not about tox, but sort of about antibiotics. Wasn't sure if there was a chance to ask it, so I'm bringing it back up now. A lot of guidelines and suggestions for pyelonephritis starts with ceftriaxone, and I just keep wondering, like, do we really need to start like IV antibiotics and then like switch them down the next day, or do they then go on to OPAT for a little bit, or we can just start them on something PO to start off with? I'm just trying to wrap my head around that piece.
Yeah, we battle that too. It's a tricky question. I think the answer depends on what you think the disposition of the patient should be. If they don't need to be admitted to the hospital for any other reason than IV antibiotics, then they don't need them and they can probably go home. If you think that they have access to get oral, like if you're trying to think of like social dynamics, where are they able to get this medication, that kind of stuff. Again, not a great reason to admit for sure, but I know that we have to do that. But no, there's no clinical reason why you have to start with an IV dose for pyelonephritis.
So like starting with, I guess, Fixine, which I guess is closely oral equivalent, that should be fine.
Yep, that's correct.
Okay, thank you.
Awesome. Thank you so much.
You probably enjoyed that as much as I did, and it was so much useful information. And I'm glad we had a lot of the pharmacy department here, and I hope you get some inspiration as well. By the way, we appreciate all that you do already, but look what else could be done, Liberate from the chains of med history. Okay. Don't think that'll ever happen. Thanks, everybody.